Okay, great. I think our numbers have steadied up off just a little bit, so I'll go ahead and get started. First of all, I'd like to welcome you all to this year's NIH Behavioral and Social Sciences BSSR Festival. Um, I am Dana Green. I'm a health scientist administrator in the Office of Behavioral and Social Sciences Research, and I'm also a member of the planning committee for this event. So again, uh, thank you again for being here and welcome all. I hope you enjoy the talks as much as I know I am going to today and the rest of the planning committee. A few housekeeping things before we get started. Today's event will run from 11 until 4 p.m. There will be 4 sessions covering research on the topics of communication, stigma, determinants, and youth. We will also hear opening remarks from OBSSR's director, Dr. Jane Simoni, and we will drop a link into the agenda in the chat momentarily. Each presentation throughout the day will be followed by a Q&A session. Excuse me. All attendees will be muted during the webinar and the chat feature is disabled. However, questions and comments will be taken via the Zoom Q&A feature. So in order to ask a question or send a comment, click on the Q&A at the bottom of your Zoom screen, type your question and send. The messages will be received in real time and the session moderator will select questions to read to the speaker during the Q&A portion of each presentation. You have the option to like other questions to avoid duplicate posts or duplicate questions. And the most liked questions will be moved to the top for answering. Please feel free to send a question at any time during the event. As a reminder, today's event is being recorded and the recording will be available in about 1 month on the OBSSR website. So first and foremost, we're really honored to have such an amazing slate of speakers joining us today who are nominated and selected by colleagues across the NIH to present at this annual festival. We thank you for being here and we celebrate you and your exciting work. And thanks to all our participants who are tuning in today. And with that, I will now turn it over to our office director, Dr. Jane Simoni, who came to the NIH at the end of July from the University of Washington. She will give an overview of BSSR at the NIH. Dr. Simoni, the floor is now yours.
Okay, thank you very much. I think you can all see my next slide. Well, I'm just thrilled to be here at my first BSSR festival as the director of the office and excited to talk to you. I'll tell you a little bit about our office and first about myself. I come from academia, most recently 23 years at the University of Washington, where I was a clinical psychologist, trained as a clinical psychologist, did mostly clinical and health psychology research in the area of HIV/AIDS specifically, and was involved in a clinical training program of the graduate students. And was running a couple centers on AIDS research and integrating mental health into HIV and AIDS research. But I felt like I could have more of an impact, especially after the COVID pandemic. And I guess I wasn't the only one. Some of you have seen this quote from Dr. Francis Collins after he stepped down from the NIH. And he said, maybe we underinvested in research on human behavior. And that was certainly my experience in the pandemic, seeing so many committees that really didn't have anything to do with social behavioral science making decisions when it was about people and really needed to be. And Francis Collins says this when we still have 1 out of 5 Americans without a COVID vaccine. And former NIMH director, Dr. Thomas Insall, kind of had similar sentiments. After overseeing $20 billion in research funding at the NIMH, really moving it away from behavioral science research towards more basic neuroscience and genetics, he wrote a book later that said, I should have been able to help us bend the curves for death and disability, but I didn't. For the most part, the advances in neuroscience haven't yet benefited the patients. This is true when I think about my area of HIV in particular. Without attention to the behavioral and social sciences, the promises of even the greatest biomedical breakthroughs like the vaccine for COVID-19 can fall short. So I think about oral PrEP and HIV. It can be a game changer, but there's low uptake and inconsistent adherence. There's initial resistance from HIV care systems. There's stigma in the community, so behavioral, structural, social reasons for not having an uptake. And in the voice trials, we learned that we can't determine if a product works or not if people don't use it, said Jeannie Morazzo. Let me tell you a little bit about our office here. It was started in 1993 with a congressional mandate and opened up in 1995. And we are responsible for coordinating the health relevant behavioral and social sciences at NIH and identifying challenges and opportunities to advance these sciences at the NIH. So we sit within the DPCPSI, a larger division of all the program coordination, planning, and strategic initiatives in the NIH Office of the Director. We have a new director, Tara Schwetz, that just stepped in last week. And we're one of the 14 offices there that oversee across all the 27 institutes and centers at the NIH. Past OBSSR directors have really been incredible leaders in the field. I'm proud to be a part of this list. I hope we can live up to the work that they have done. Dr. Christine Hunter, I'd like to single out for stepping in for the last year and a half as acting director before I was hired. And in terms of our leadership, not only myself stepping in July 30th, but Janine Simmons, we're happy to announce, coming from the Institute of Aging here at NIH, will be joining our office. She's already here on detail, but we're starting officially in January. And Wendy Smith is our associate director, who has been here over 15 years. We're excited in the office that we hired 2 new supervisors, one from the outside, Roz King, who is now our chief of a scientific development and coordination section. She supervises all the health science administrators, and Katie Morris, promoted from within the office, who is the chief of the policy planning and analyses section, overseeing all the HISPAs, or our health science policy analysts. We have a large, diverse, and terrific staff here at OBSSR with 2 new folks. I want to point out Lauren Fordyce is our most recent staff member. Lizette Rivera Arnold also is coming in on a contract to assist us with product management, and Adam Politis, who is the month he joined, he left, actually the week he joined, he left to the White House on a detail working on disability policy. But these are across the board, our health science administrators and the policy analysts. Our mission then at OBSSR is to enhance the impact of health-related BSSR, which is important, right? Because NIH even had in its name, they were a biomedical institution, but really they're a health research institution in the behavioral, social, and sciences. Have an office now that they can impact this. We coordinate all the research conducted or supported by the NIH and integrate this BSSR research within the sciences and the larger NIH mission. And then we communicate these findings to various stakeholders, both within and outside the federal government. Our budget is small compared to some of the larger institutes, which have institutes in the several billions of dollars. We had 41 million in FY23, but it's increased steadily over time with a large jump in FY22. And 80% of our budget we get to give away to fund the highest level and best BSSR research across all the institutes at NIH. So it's exciting to be able to do that. And you can see this co-funding mechanism for last year, where the money has gone. So most of it to the National Institute of Mental Health, not surprisingly perhaps, but then for aging, for mental health and health disparities, for child and human development, for NIDA, for drug use, heart, lung, and blood, and down the line. So it's kind of fun part of my job. When I was in academia, I was hustling to get grants, and now I have the pleasure of actually funding, or at least in part, some really exciting research, some of which we'll hear about today. And then the amounts that we give away by fiscal year, you can see to over $30 million in the last few years, with that big jump during the COVID epidemic, instigated in part by the COVID epidemic, with some of our allies championing our cause in Congress for that increase. I'll talk about 3 of our priorities and some of our cross-cutting themes or foundational processes. But our main priorities are improving. This is in our fiscal plan and strategic plan currently in effect. Improving the synergy of basic and applied behavioral and social science research. Enhancing and promoting the research infrastructure by looking at methods, measures that are needed to support a cumulative and integrated approach to BSSR. And finally, facilitating the adoption of this research in health research and in practice. So those are our main priorities. And we have 4 foundational processes through which we accomplish this goal. The first is training, to train the next generation of behavioral and social science researchers. We support multiple scientific training courses. We coordinate programs across the NIH and integrate behavioral and social sciences research into the larger NIH. We have a communications office in which we communicate our findings to a broad and diverse audience of stakeholders within the NIH, to the behavioral and social science research community at large, the biomedical research community, policymakers, health practitioners, and the general public. And finally, we're dedicated to strengthening the ability to manage and monitor the BSSR portfolio. What grants are we funding? What are we looking at? What are gaps? What are possibilities and opportunities that we have? Because we want to be able to identify more rapidly research trends, advances, and gaps to help in the future. I'll give you some of the examples of what we do with these processes. So for training, we have a T32 training in advanced data analytics, where we focus primarily on doctoral level scientists to make sure that they have the methodological skills necessary to do the work they do. We offer short courses with an R25 mechanism on innovative methodologies and approaches, and we just awarded 6 for the current year. Then we have administrative supplements to NIH-funded T32 and TL1 training grants, so we can better integrate behavioral and social sciences with other health-related sciences. And many of these opportunities are open every year, so I hope that you will, those of you listening, might be able in a position to apply for some of these in the future. In terms of coordination and integration, what do? We have an excellent coordinating committee, an NIH BSSR coordinating committee with members from all across the institutes at NIH who work on behavioral social science research with very active working groups to support the work we do. We have an integration report that was published recently, and we have advanced data analytic tools that we're working on so that we can better monitor the work that's done here at NIH. We have a co-funding program that I told you about, where we actually provide research funds for other institutes when they recognize important BSSR work. We have an open science webinar series, and we're involved in several NIH-wide large initiatives: HEAL on pain and opioid epidemic, ECHO on the environmental factors in children's health, brain research, COVID research, social determinants of health, maternal health, music and health. We have an adherence network and a Compass, a community common fund program. So large NIH-wide initiatives that we're very much involved in. In terms of communication, the Matilda White Riley Honors Lecture in the spring is something we're proud to present every year. We have this research festival in an annual format. We have a webinar series and a connector newsletter that comes out monthly with a blog. We have a BSSR accomplishments project. This is listed on our website. And we have a history timeline about the work that we have done. In terms of policy and evaluation, we have a strategic plan currently in effect, and there'll be a new one coming out in January. I look forward to talking to you about that and some of the blogs and presenting it next year at the festival. We have time-sensitive opportunities for health research. We know a lot of the work in behavioral social science hinges on particular timing, and so we have a notice of funding opportunity for this. We have resources for clinical trials work and support. We do a health economics analysis, and we have a group on the future of work, what will look like, and what is the future of scientific conferencing, including a workshop coming up in the spring. We also have several large initiatives that either are led or co-led by our office. One we're particularly proud of is the violence research initiatives, including the firearms mortality and injury prevention research, funded from Congress directly to our institute, giving us an additional 30% to our budget to be able to spend. We also do work on a workshop that's coming up, understanding and addressing health impacts of online abuse and harassment. And we have the social, behavioral, and economic impacts of COVID initiative that we have run for the last few years. We also have the BRAIN initiative. Again, I said we're involved in basic science research as well as applied. So call it BBQS. It supports the development and validation of next generation platforms and analytic approaches to precisely quantify behaviors in humans. This is the behavioral connection that the more biomedical science really appreciates from our office, and to link them with simultaneously recorded brain activities. We have a couple open RFAs for these. I urge everybody to take a look and see if you might be eligible to apply for them. We also have a basic behavioral and social sciences network, originally called OpNet, funded by a common fund, but continues to look at cross-cutting basic behavioral and social sciences. We also have a behavioral ontologies report, and we commissioned the National Sciences of Academies to look at this way of looking. There's a way to explain it to you. You can't look at and analyze what research is being done in terms of the SSR if you don't have the terms to do that. So a huge project to look on the best ways to study what has been done in the area of behavioral science, and then to stimulate further work in these areas by pointing out gaps that aren't covered. And then we have research and application and team science, and a NASEM consensus study that started in August 23 to understand how team science can best be supported. Of work and health-related research. And you can see that this is something that definitely cuts across all of the centers at NIH, and that's an important part of what we do. So our interest areas for our co-funding, we thought about 5 different areas that we really wanted to promote and emphasize in our work. So the first is behavior change, maintenance, and mechanisms of impact. And this is theory-informed research on the initiation and maintenance of health-promoting behaviors and mechanisms, both in behavioral and physiological interventions. We also are very much interested in social connection and health. So research that examines the role of social relationships and interactions on health. And these can be the mechanisms through which these social isolations or connections accelerate or impede biologic and other disease processes that affect the execution of health behaviors and that overall impact health and well-being. And you might notice this is something that the Office of the Surgeon General is very much interested in, and we are working with them on this as well. So 3 other areas. One is not a topic level, but a methodological level. We're interested in multi-level research. It's hard to do, right? Not looking at something just at the individual level, but at the biological, interpersonal, community, organizational, structural, environmental, and policy. You don't have to do all those in one study, but looking at even more than one would be an improvement in a lot of the work that's being done currently. And we would like to support that with our own research funding. Health communication science, we saw and we heard from the former directors of NIH talking about how there were lapses and what behavioral and social science could have done during the pandemic, and in the importance of it in general, and patient care, and preventive and other health promotion interventions. And we want to look at that science with additional funding. And finally, we're looking for ways to integrate behavioral and social sciences research into the biomedical research community writ large. So are there research training initiatives and other programs and workshops that have typically really focused on biomedical issues, but that could really benefit from looking at behavioral and social science as well? Again, those of you who might be eligible and know those eligible for funding, we have multiple. These are all on our website, by the way. We'll send copies of this later so you can see, but these are notices of our funding opportunity right now, looking at structural racism, discrimination, health disparities, the HEAL initiative on substance use, ethical, legal, and social implications, small research program, firearm prevention, Native American health, and family support and rejection in health for the well-being of sexual and gender minority populations. So really a diverse range of different opportunities in the behavioral and social sciences. I finally want to give a nod to I had mentioned this coordinating committee we have. These are our representatives across almost every single institute and office. That's our goal, to have everybody represented in this committee. So this way we coordinate not just research in our office, but research across the entire NIH. Some of you might recognize some of the folks you have worked with, or your project officers of course, the different institutes, and they work very directly with us. Upcoming events, we have the seminar this week on understanding and addressing the health impacts of online abuse and harassment workshop. I hope you'll be able to attend. And in March, we have a webinar on social connection with Dr. Julian Holt-Lunstad from Brigham Young. And we have the director's webinar on social and computational science with Dr. Dimnit Gabru at the Distributed AI Research Institute. So exciting new and innovative BSSR research that we want to bring to you. And finally, at the Wednesday afternoon lecture series, the WALS lecture series, a very prominent lecture series at NIH, we're particularly happy that our choice of someone to represent the behavioral and social sciences was selected. Dr. Jenny Tung will be speaking in May. Again, all of these are listed in our news and events section on our website. In June, we have the Matilda White Riley annual event and a lecture to be announced, and the Behavioral and Social Science Insights for the Future of Scientific Conferencing, a workshop, and 2 days in June. We'll have a webinar on the intersection of social science, aging, and health disparities with a talk by Dr. Rebecca Wong. And finally, looking forward to September, another director's webinar on justice-involved individuals and access to healthcare with Dr. Emily Wong, Yale University. Again, everything's listed on the website, and we'll be sending out notices of those of you who are signed up to receive them. Before I end, I just want to give a nod to this festival planning committee. It takes a lot of work to put together a festival like this. These are folks inside and outside of the office who work together to bring this to you, and I wanted to thank them here publicly for the work they're doing on this. And I'll end with a request, an invitation to stay connected with us on any social media platform you use, to subscribe to our newsletter at this link, and to learn more about our office and what we do. And now I'll turn it back over to Dana, and I'm happy to address any questions or comments that folks might have from the audience.
Jane, that was an exciting and very good background of OBSSR and where we're heading. I'm waiting to see if there's any questions that have come up into the Q&A box. Again, the Q&A is at the bottom of your screen. If you have a question for Dr. Simoni, please type that in.
While we're waiting for any questions, I can tell people they often ask about my vision for the office. You know, what will that be like? And there will be a strategic plan. We have a good draft of it that I came into the office with, but we will be announcing that hopefully in the first quarter of next year. But I'll say very much we're focused on implementation and impact. So we are very supportive of basic science research in the office, and we want to make sure this gets turned into implementation work and implementation, both in other research settings and in healthcare directly, so we can have an impact. And we want to show that across OBSSR, how we can impact health.
Terrific. There was a question in the chat just asking if you will be sharing your slides, which we will. That was from our colleague at NIEHS, Alfonso, which is great to see you on the chat, Alfonso. Miss seeing you in person. Oh, and here comes another chat for you, Jane. This is from Rita Sharon. Is OBSSR committed to engaging the humanities in our work? So much is going on in narrative work, creative training of scientists and clinicians that fit in all of our work.
Thank you for that comment. I do like to think of BSSR as very inclusive. We talk about the behavioral and social science, but oftentimes we often include economic analyses of what we do. And I certainly would hope that I think about narrative analyses, think about in-depth qualitative approaches as very much a part of the behavioral and social sciences. So I would like to include that in our work, and you're welcome to reach out to us or to me directly if you have particular ideas that you think we could be doing a better job with that.
Perfect. Okay. Another question is, are there connections BSSR is making with One Health, interactions at the animal, human, and environmental health interface?
That is One Health a particular initiative, or are they just a concept that they are thinking of?
Honestly, I have not heard. That's the one thing I have not heard about.
Okay, and Dana would know it if we.
I would hope so, but it sounds like a great concept.
Yes, definitely. And I think it fits in with when we talk about multi-level research. working at many different levels. A lot of our co-funding does go to research with humans, but a lot of the basic research that Dana's involved with, I mentioned the VPQS program, it relies on more basic research with animal models, but it's certainly a part of what we do and what we connect with. Yeah, I would say we tend to be very inclusive. I don't know if you wanted to add anything to that, Dana.
And the person that asked the question said that One Health is an initiative that is known perhaps more in veterinary medicine. So that does make sense. So we do have things that are aligned with that, as you were mentioning, Jane.
Yeah.
And I'll definitely have to take a closer look at that. So thank you for pointing that out.
Yeah.
Another question is implementation studies and multi-level studies sometimes require large funds. What is your strategy to promote those studies under the current budget constraints?
I know. I wish, there actually was a mechanism at NIH this year that increased the budget, but those seem to be pretty tight ceilings on some of the mechanisms. I know as a researcher, because coming from academia, that the R01, for instance, budget level hasn't increased in a decade or so. So it is difficult to do that research. It's difficult to do implementation studies when, you have N of 3 and each of the sample is an entire clinic or an entire system. So there are difficulties to do that. We are helping by kind of contributing, offering supplements to some work that can be done by co-funding studies at larger institutes that have more money and sometimes can spend more than can go above the R01 limit. But I recognize that is difficult. And I think that's sometimes why those kind of studies aren't done. It's just very difficult to do within the constraints of the current budget mechanisms. But excellent question.
Great. And I have one more question that was just more about, well, there's a couple of questions that go into funding, and I don't know if you're going to be able to exactly answer them, but it is talking about funding for individual social scientists, which I know is sometimes a challenge for NIH. And then the other one is also talking about the best way to point or route faculty that don't currently have funding. How would you direct them from the educational school, especially, or early education?
Yeah, those are good questions. We do support individual people with our training programs, right? That aren't just for early stage investigators, but the NIH supports mid-career, even senior career level scientists, especially those who continue to mentor. There are many programs for that. So we do support individuals. And in terms of directing people to the best way, take a look at the website, find out the institutes that are most in line with your interests, and reach out to the project officers. Look for the notices of funding awards, the ones that in your area, and they will always have a point of contact at one of the institutes, and you can reach out to them. They often give their telephone number even, or email, and do try to meet them. Go to conferences in your area and reach out. We often have NIH staff at conferences. Get to know them, and they are excellent mentors, not just science administrators. And Dana, I don't know if you'd add anything to that.
You've actually covered it exactly the way I would have said it, Jane. So
okay,
great
good
job.
Good to know. Still.
And with that, we are at the 11:30 time. So I want to again thank you, Jane, for your fabulous talk. And I would like to go ahead and go on to the first session, which is moderated by Stephanie George from NIAMS. And with that, Stephanie, I'm handing it over to you.
Excellent. Thank you so much. It is my ultimate pleasure to be here today to moderate this session. I am a program officer. My name is Stephanie George. I'm a program officer and an epidemiologist at the National Institute of Arthritis, Musculoskeletal, and Skin Diseases, and I serve on the BSSR-CC that Jane had just mentioned, and I'm on the planning committee. So this first session today will focus on health communication. Our first speaker is Dr. Brittany Smalls, who is an associate professor of medicine, the Dr. Claire Louise Caudill Professor in Family Medicine at the University of Kentucky. And Brittany will be speaking today on playing telephone with trusted health information in a rural Appalachia, Kentucky. Brittany, you're up.
Thank you so much. Give me 1 second to share my screen and I will get started. Thank you all for joining. Thank you all for choosing me to be part of this wonderful festival for today. As Dr. George says, I am at the University of Kentucky, and today I will be talking about some of the work that I've been doing in rural Appalachia, Kentucky, and understanding how trusted health information is actually disseminated through the community. So I want to start off by saying I have nothing to disclose, in that the project that I'm going to be discussing today is funded by NIDDK. So I'm sure we've all heard of playing telephone, you know, particularly as a kid. It's always very interesting to know what was the first message versus what the last message ultimately ends up being. And this is true for a lot of things that we experience throughout our life course and in different situations. And so I was interested in knowing, how is this information being disseminated through a rural, low resourced, geographically isolated for the most part community. And so some of the challenges of effective health communication in rural Kentucky are that there are fewer than 50% of residents who hold a bachelor's degree or higher. About 30% of Appalachian adults are functionally illiterate, and there's a lot of medical mistrust and distrust. And to be honest, a lot of it is warranted, but unfortunately, that mistrust and distrust is associated with underutilization of medical services, lower preventive screenings, increased likelihood of self-reported fair or poor health, physician mistrust, and poor communication with health providers, which of course trickles down into health behaviors, how people view the health system, and ultimately whether or not they choose to make decisions that will promote optimal health for them, their families, and within the community. And so one thing that I have learned in working in rural Appalachia is that there are a lot of social support and interpersonal relationships that can be leveraged. A lot of these communities are very close-knit, and there's a high level of social connectedness. There's a lot of local knowledge. Like, there are people who are informal leaders, informal folks who are like key assets that a lot of information flows through. And so understanding who those people are and how that information is disseminated can also be helpful for us to understand how we can better leverage those relationships to promote health. And then there are the other informal methods of communication through community organizations or community groups, family, friends, and those types of relationships. And so I was asked to speak today based off of this particular publication that I had earlier this year. And so I'm going to break down what we did, but I also just wanted to give everyone, you know, the citation for this publication if you wanted to read more about it. And you can definitely reach out to me if you have any questions, if time doesn't permit for the question and answer session. And so the research objective was to use social network analysis to evaluate how trusted health information is transmitted in rural Appalachia, Kentucky, and to determine the main providers of this information. And so the first question may be, what are social networks? A lot of people associate social networks with social media, and sometimes use those terms interchangeably, which they are not interchangeably. They're not the same thing. And so social networks is actually a method, a quantitative method of assessing interpersonal relationships and the strength of those relationships. And so I'm going to talk a little bit more about that so you guys understand what I'm talking about as I provide insight into what we found for this research. And so we start off with a person, which we call the ego. And so what we were trying to do is develop egocentric networks for community members to understand who they are getting trusted health information from. And so that's very key. This is not who's in your social network, but who in your network can provide trusted health information to you. And so for each person that is indicated, they are called alters. And so you see how the lines go to each of those individuals. And then we also want to look at what are the ties between alters that may not impact the ego. And so that gives us an indication of interconnectedness and just how information may be flowing within a particular person's network. And also it gives indication of, are there external, like the external ways of getting information, or is the same information being kind of telephoned through the same network? And so all of that comprises a social network. And so for the study, we decided to go at the community level and one, look at the individual and ask them about their social network. And then we took all of that information to try to see if any of these individual networks connected to other people within the study, to kind of get an understanding of the community level impact of how trusted health information was being distributed throughout the community. When I originally submitted this grant, I wanted to do a snowball method. And for all you researchers out there, you know, sometimes when you get into the crux of it, what we ideally want for a recruitment strategy or other things doesn't happen the way we want. So we ended up using a community liaison to kind of help us identify people within the community to participate in this study. And so, like I said before, our first question, our main question for this study was, please identify 3 people in your community who you trust, and you can get good or reliable health information from. And then to counterbalance that, because that's a very subjective question, right? But we also wanted to understand the level of social support, because this is social networks in this regard also kind of taps into what social support, what we think about social support and how it may interplay with relationships. So we also asked them very specific questions about the type of support that they were getting from these individuals outside of the health related aspect. And so another way we evaluated these relationships is we asked people to measure on 1 to 10, or indicate on a scale of 1 to 10, like how much contact they felt that they had with this person, with 1 being the least amount of contact and 10 being the most amount of contact. And that's more of just like a perception. Do you feel like you're always with this person? You know, you feel like you're always talking to this person. But then we also had something that was a little bit more objective, where we asked them the number of days per week that they actually had contact with that person. So is this like, you know, an everyday thing, or is this just like a once a week, but you feel like you spend the whole day with that person for that 1 day out the week? So it kind of helped us determine the true strength of the relationship and the amount of interaction these individuals are having with the ego. We also asked for frequency, specifically the frequency of health information that was being discussed during these interactions, and also the value of the information that the ego placed on the information that they were receiving from that individual. And we also looked at the type of relationships. So was this a kin relationship or a family relationship? Was this like a friend or a neighbor? Was this like a doctor or therapist? Or was this someone that's part of like a group, like a social group or society or club or something like that, where these relationships were developed and these interactions took place? And so the big question is, who are the sources of health-related information support in rural Appalachia? And so we, first, I want to just give a little bit of background on the participants, on the egos that we interviewed. And so most of them were female, 43 years old. A lot of them had less than a high school education or less. A lot of them were insured, which was good to see, and a lot of them were still employed, whether full-time or part-time. And so going back to the social support questions that we gave them, these questions are on a scale of 1 to 100, how they were scored. And as you can see, a lot of the answers, the mean answers for these questions fell within the 3rd quartile. So so in that 50 to 75 score is where a lot of these people felt that essentially they felt supported by the individuals that they indicated for trusted health information, which is good to know. And so when you look at, can I trust this person with my health information, but then can I also trust them to provide me with support, to listen to me when I need to talk, or to have just general support, or to provide me with good advice, or, so those things I think are very helpful, because it's not just the trusted health information, but it also displays the trust based off of the support that's being given in general, in these general interactions. And so we also found that people were reporting out of that 1 to 10 scale that they were falling around that 7. So they felt like they were having a lot of contact with the individuals in their networks. And they also felt that they were, or they also reported that they were talking to these individuals between 3 to 4 times a week, which is a lot. And one thing we have to bear in mind, that all of this is self-reported, but it's also very interesting to get this level of feedback, especially for this particular group of individuals. And then we also found that the conversations that they're having with these individuals, most of those conversations were frequently discussing a healthy lifestyle, and most of the participants found the interactions to be very valuable or very valuable. I think a very interesting thing that we found was that friends and other medical professionals, so those who are not physicians, were actually considered to be like the top ranking relational roles that we found, which was a little bit surprising, because in rural Kentucky, especially in Appalachia, we find a lot of families are very close knit and have a lot of influence on decision making. And we also find that there are faith and religiosity and spirituality are really big. And so to find that, church or a priest or some sort of faith-based leader, in addition to family members, were not included or not highly ranked as someone that our participants thought could provide them with trusted health information. And so this is just an example of what of our participants in some of the networks that we found, just using that altar, the person in the middle, that green dot, and then the seed, and then the altars are the red dots. And so you can see how these relationships, based off of frequency, based off of what we consider quality of the interactions and how close they are. You also can see the interconnectedness. Some of these social network maps you see all the lines go through, and you have several lines, and some of them you just have the altar in the middle that are going out to the seed in the middle going out to the 3 different altars, and the altars aren't interconnected. So this is actually very, very interesting to see how some of these relationships work. So we found that most of the altars were able to name 3 people. Most of the seeds were able to name 3 altars, which was good. But we also had some people that weren't able to name 3 people in their space that they felt that they can have a conversation about trusted health information. And so that is interesting in of itself. And I also want to point out that this what I'm reporting on is based off of the paper that was recently published, but that's not all of our data. And so that was so we're still working on this data, working on analyzing it, and kind of getting a better a fuller picture of how these relationships and social networks are working with one another. And so here is us putting all of the networks together, the individual networks together, to see where there may be overlap, which is really interesting, because on the right side of your screen, you can see where some of the individual networks come together, and there are people who are named multiple times by multiple people in the study as trusted sources of health information. And then on the left side of the screen, you can see where there are the networks are very egocentric. They're not connected. They're and so the question becomes, how do we kind of bring together this network at the community level to make it so that we are getting more information and people feel more connected, and that trusted information is being spread evenly. But it poses a challenge, as I'll discuss in my next slide, because what what we find is that there's so many different barriers that contribute to why these networks may be this way. And so the question is there an opportunity to create a more cohesive community network for trusted health information? In order to do that, we have to actually identify what are the barriers? Why are some people so connected and other people so disconnected and spread out? We had one person that wasn't able to name not a single person they can get trusted health information from, that they interacted with. And so that's also like an issue. And like I said, this is a relatively small snippet of a community, but even it's only some of the data that we have. And so we will, with some of the other data, we also did some qualitative interviews. We will be able to do a mixed method approach to kind of really delve into some of these interesting findings we found in this preliminary data. But I think what's also interesting is, those sources, those people that we found that seem to be the center of trusted health information. Those individuals, I think, could be very beneficial to becoming, community champions, community health workers, however you want to describe them. If we can train them, if we can get them information that is going to be beneficial to their community, and be able to be a voice, and be able to relay that information, I think would be very helpful. For me in my research, I primarily focus on cardiometabolic disorders. This study in particular will eventually get to looking at diabetes. And so I think that one of the things that's really interesting in rural Kentucky is that diabetes, the prevalence of diabetes reaches 23%. And it's partly because people think it's just a natural progression of life, of their lifespan, of their life course. So having these champions and teaching people about preventive measures or how to better manage their diabetes, and that complications and severity doesn't have to be their lot, then that could be something that could actually be kind of revolutionary. Could be something that could save lives and change the trajectory of a lot of families and family history of diabetes and other diseases that are have high prevalence in those areas. But I think another thing is the fact that there's a lot of trust being put in friends, which it makes sense. But I think the other thing is non-physician healthcare workers were the second highest named as trusted sources of health information. So looking at community nurses, nurse practitioners, people who are in those communities who are not physicians, maybe because of physician mistrust or distrust, we don't, at this point, I don't know, but using allied healthcare workers as another avenue for having these conversations and promoting health and well-being in these communities is another thing to also consider moving forward. And I believe that ends my talk. Thank you all very much for listening and for having me. And if there's time, I will take any questions you all may have.
Thank you so much, Dr. Smalls. We are actually out of time and need to move to the next presenter, but there is a question in the chat that I'll read out to you, Brittany, and perhaps you could, we can type that answer in to the live feed here. Were the questions you asked participants grounded in a social support theory or derived from a pre-existing scale? So if you could just answer that one in the chat for everyone, that would be awesome. Thank you so much. So our next speaker, I'm pleased to introduce Dr. Merit Talabi. Dr. Talabi is an assistant professor of medicine in the Division of Rheumatology and Clinical Immunology also an assistant dean and co-director of the Pitt CMU Medical Science Training Program at the University of Pittsburgh School of Medicine. And Dr. Chalabi will be presenting on how to provide sexual and reproductive health care to patients, focus groups with rheumatologists, and rheumatology advanced practice providers. Thank you.
Good morning, everyone. Are you able to hear okay? I'm hoping so. I'm just going to keep going then. Such a pleasure to be with you today. Thank you to the meeting organizers for having me. And again, I'm going to share some of our work about how to provide sexual and reproductive health care to patients, focus groups with rheumatologists, and rheumatology advanced practice providers. I have no disclosures, and these are the disclosures of my co-authors. So birthing people with rheumatic diseases, and these are the diseases that we as rheumatologists treat. They include autoimmune and connective tissue diseases. These diseases are associated with an increased risk of adverse pregnancy and perinatal outcomes. For example, diseases such as systemic lupus erythematosus, or lupus as it's commonly known, is associated with a 5 to 20 times higher risk of maternal mortality as compared to general population, in part because of the activating effects of estrogens on the immune system. But we also see adverse pregnancy and perinatal outcomes across many diverse rheumatic diseases, including antiphospholipid syndrome, Sjogren's syndrome, vasculitis, scleroderma, myositis, rheumatoid arthritis, and spondyloarthritis. An example of that is psoriatic arthritis. And across these different diseases, we consistently see an increased incidence of miscarriage, stillbirth, preterm birth, fetal growth restriction, and preeclampsia. I think a really important point is that active rheumatic disease at the time of pregnancy really drives a lot of these adverse outcomes. We know that people whose diseases are well controlled for 3 to 6 months prior to pregnancy have much better outcomes than people whose diseases are not well controlled. And I think that really emphasizes that pregnancy timing, when possible, can be a critical means of facilitating better reproductive outcomes in rheumatology. It's not just the diseases, it's also the medications that we prescribe to control the diseases that can threaten healthy pregnancies in the rheumatology context. I want to emphasize that in rheumatology, we have a number of medications that are indeed pregnancy compatible, but some of our most commonly used evidence-based and cost-effective medications are not compatible with pregnancy or lactation. And that includes examples like methotrexate and mycophenolate, both of which are associated with an increased risk of pregnancy loss and a 7 to 25% incidence of congenital anomalies for exposed pregnancies. So I think a really important point here is that sexual and reproductive health care has its place in rheumatology care. It may facilitate open communication between the patient and the provider about the patient's goals that might lead to better outcomes. For example, avoiding pregnancy at a time when a rheumatic disease is active, or when a patient is using fetotoxic medications. Or pursuing a high-risk pregnancy, even though it might be medically ill-timed technically. Somebody who wants to have a family may pursue a high-risk pregnancy, but by communicating about that with a rheumatologist can help to get maximal support from their provider team and also optimize their medications and their disease before entering into that pregnancy state. I think one of the interesting points, and it may not be an intuitive point, is that the current role of the rheumatologist in providing sexual and reproductive health care is really somewhat unclear. We as rheumatologists, again, treat autoimmune and connective tissue diseases, and about 80% of the diseases we treat occur in people born female. These are female predominant diseases. Nonetheless, we do not have a clear established framework for providing sexual and reproductive health care in the rheumatology context. Many rheumatologists in our foundational work do not provide consistent sexual and reproductive health communication to patients. Most rheumatologists do not prescribe contraception. In fact, only about a third of our patients are prescribed contraception, despite some of the issues that we've just mentioned here. Many rheumatologists also defer care to other providers during pregnancy. So that's a really important point here, because we as rheumatologists are subspecialists in rheumatic disease. We can manage these diseases arguably better than others. And so during pregnancy, we really should have a more active role in helping people to have safe pregnancy outcomes. So we wanted to first acknowledge that we need to better create a sexual and reproductive healthcare framework within rheumatology. But we felt like we needed to go to the rheumatology clinicians themselves in order to find out what their barriers and challenges were to establishing this framework of care. And could they help us to brainstorm some potential solutions for navigating around those barriers and challenges? We thought that these might be particularly feasible and acceptable if these solutions were coming from the rheumatology clinicians themselves. And so I'm going to share with you some of the results from our study that focuses on this issue. So what we did is we engaged US-based rheumatologists and rheumatology advanced practice providers, or APPs, in virtual focus groups. I think a particular strength of this study is that we did include advanced practice providers. They've got a growing role in clinical care, but they've rarely been studied in this context. We did acknowledge, though, that rheumatologists and rheumatology APPs do have some differences in their practice patterns. Rheumatologists tend to have more complicated patients and have less time for clinic visits. And so we recruited rheumatologists and APPs to separate focus groups, as we weren't sure if some of their barriers and challenges were going to be the same or if they were going to differ. The focus groups were recorded and transcribed. They lasted for 75 minutes each. And we had trained interviewers who led the participants through a discussion of different barriers and facilitators to sexual and reproductive health care, elicited participants' current practices related to family planning. And in a brainstorming exercise, interviewers led participants through brainstorming to help the clinician in your practice who you think is least likely to provide sexual and reproductive health care to people with childbearing potential. In other words, we asked people to brainstorm for the curmudgeon in the clinic, if you will, who might be most uncomfortable with or least accustomed to providing sexual and reproductive health care to patients. We then ranked each solution by order of preference by the different participants, and we used established qualitative methods to analyze the data. Okay, so what did we find? So we had 5 focus groups altogether. We had 3 groups of rheumatologists and 2 groups of rheumatology advanced practice providers. Overall, rheumatologists and APPs had practiced for at least several years. The majority of participants in this study were self-identified as female, about 60% of the rheumatologists, and all of the advanced practice providers. Most of the rheumatology clinicians were practicing in academic settings. And I should mention too that our recruitment was mainly with referral sampling. All right, so I want to start talking about some of the barriers and challenges that rheumatology clinicians mentioned in the different focus groups. And one of the main challenges across the board was a lack of sufficient clinical time to address sexual and reproductive health. As one rheumatology clinician said, for providers in a 15-minute appointment, they're trying to cover a lot of material. And so I'm not sure that sexual and reproductive health care is always first and foremost in their minds when they're meeting with the patients. Providers also felt that patients weren't necessarily primed to communicate about sexual and reproductive health care, which is not surprising, as I've mentioned, we really don't have an existing sexual and reproductive health care framework within the rheumatology context. And what could happen is if the patients weren't really primed to have the conversation and they hadn't really refined their conceptualizations around family formation, these conversations could linger, and clinicians wanted to avoid running over in their schedules. So one of the solutions that they generated was to prepare patients to engage in sexual and reproductive health conversations before and during clinic visits. One of the really popular suggestions across the different providers was providing patients with forms or checklists that were given longitudinally and might ascertain current sexual activity, pregnancy, planning contraception use, or perhaps a need for an OB/GYN referral. These forms would be helpful for priming and preparing patients to talk about sexual and reproductive health care, but also could remind the rheumatology clinician to make sure that they address sexual and reproductive health care as well. We also heard time and time again from rheumatology clinicians that cross-disciplinary collaboration was really, really needed. As one rheumatology clinician mentioned, there are so many things I can't advise well on Nexplanon and the bleeding pattern that you get with that and how it's different than the bleeding pattern with intrauterine devices. And I would never have thought about that as a reason to choose one method over another. So I think OB/GYN experience is extremely valuable. I want to just mention here that none of the rheumatologists wanted to take on or rheumatology APPs wanted to take on the responsibility for providing contraception. Again, that's not a normal or typical responsibility for rheumatology clinicians. And they really did want OB/GYN's involvement, but many of them indicated that they did not have a dedicated practice or OB/GYN or even maternal fetal medicine or family planning specialist to whom to refer patients who might have an urgent contraceptive need, for example. With that in place, and that context in place, perhaps it's not confusing that really rheumatology clinicians wanted dedicated consultation systems. They wanted the ability to have a referral system with dedicated OB/GYN and maternal medicine, fetal medicine providers that they could, again, sort of quickly refer patients to as needed. I want to mention that that was a challenge in and of itself because very few of the rheumatology clinicians in the study actually had such a practice or a person in their own clinical practices. And they acknowledge that it would be a challenge and a barrier to set up these referral patterns, but these should be system-wide approaches to helping to facilitate sexual and reproductive health care as well. Knowledge gaps were a major issue on behalf of the rheumatologists, especially around medication safety in pregnancy and lactation. As you may remember, one of the earlier slides, I indicated that we do have medications that are safe to use in pregnancy in rheumatology, but we have some medications that are not. And in fact, most of the medications that we prescribe have unknown medication safety in pregnancy and lactation. These data are subject to change. So as one rheumatologist said, I think for a lot of our medications, there's just not a lot of data out there. That's an area I always struggle with. What's the best medication for patients who are flaring during pregnancy, post-pregnancy, or during pre-pregnancy period of time? So rheumatologists wanted more education and training around this. They wanted to have a single website or source where they could get up-to-date information about medication safety. They also wanted to know more about pregnancy management and what safe contraceptive methods would be available to patients. And again, they really wanted it in a centralized place. We do have guidelines and we are working on educational information from the American College of Rheumatology to help to provide these single websites or sources. Interestingly, even though that we have some of these resources freely available, we found through these focus groups that rheumatologists were not aware of these resources, which is going to be a focus of future work. Finally, there were major barriers to patient education that were mentioned in our focus groups. It's no wonder that if rheumatologists have knowledge gaps, that patients are going to also have knowledge gaps about the intersections between pregnancy, medication safety, and even contraceptive safety. Finding easily accessible and accurate patient information was something that rheumatology clinicians found was a real challenge. As one of the clinicians mentioned, it's so hard sometimes to find patient education, just something for patients that's tangible and that they can take with them and have for their own education and teaching so that they understand what we're concerned about too. So educational materials about sexual and reproductive health care were really popular solutions, brochures and pamphlets that rheumatologists could hand directly to their patients, referral to dedicated website, and emphasizing the importance of using existing resources to patients, especially around medication safety. So there are certainly some limitations of our study. I will mention that all of the APPs and most of the rheumatologists identified as female, and we know gender discordance between patients and clinicians might provide unique challenges to the provision of sexual and reproductive health care. This was a qualitative study. It's not meant to be generalizable, but I do want to emphasize that this study, again, is not generalizable to all rheumatology clinicians practicing in the US. So I'm just going to conclude here. We have talked about some of the gaps in reproductive health care for patients with rheumatic diseases and how these gaps might lead to adverse outcomes. I think health services research in general really can highlight not only where we fall short, but where we can do better. And I think what was really exciting to me about this study is that rheumatology clinicians were finding ways and coming up with feasible and potentially effective solutions to expand sexual and reproductive health care in their practices. I would mention that we're not the only ones who have these challenges. What we found is that other subspecialists also have challenges, whether it's pulmonologists, cardiologists, nephrologists, in integrating sexual and reproductive health care. So perhaps what we learned in our study might be applicable to other subspecialties. And hopefully the creation of a patient-centered framework is going to better meet patients' needs, their priorities, and also help to improve patient outcomes in the rheumatology context. I want to thank the organizers for the opportunity to talk with you today, and thank you to the audience for listening in. And if we have time for questions, I'd love to take some.
Excellent. Thank you so much for a lovely presentation, Dr. Talabi. We do have a question, and I'll invite the audience to please pop additional questions into the Q&A for Dr. Talabi. And also, should you have questions for any of the presenters as you go along, whether it's their talk or not, feel free to place them in the Q&A. So the first question, Dr. Talabi, is, I was reading a lot about the social determinants of health and the impact on diseases. And the more I read, the more I think most of the inflammatory diseases are related to SDH. How do you think research in this area can be performed to demonstrate that diseases like fibromyalgia can be more related to social determinants of health than genetic factors?
If possible, can I share my screen one more time?
Absolutely.
Okay, I think this may help. Let me see here. Were you able to see this conceptual model?
Can't see.
Can you see that here?
Yep, can
Okay.
see it.
So I thank you so much for that question, because we have a conceptual model actually that's addressing exactly what your question is. We are really interested in the social determinants of health, and not only how they affect immunologic disease, but all aspects of patient care, not only within the rheumatology context, certainly, but the clinical context and the structural context as a whole. We actually believe social determinants not only affect reproductive health outcomes directly, but again, may act on disease and increase people's abilities to get the care that they need to control their diseases, to be taken seriously by healthcare providers, to be given effective medications that help to control their diseases and act upon these these downstream outcomes. I just want to mention that because that's really a focus of our work. And again, the question is a good one. And I think one that really we're looking at for the future.
Thank you so much. Appreciate that. And I'll invite others, as if you have additional questions, we're going to move on to the next speaker. But if you have additional questions, please do feel free to continue to pop them in the Q&A, and our speakers can answer them that way. All right, so the last set of speakers for this session is a tag team. You can see them both in the visual. We have Dr. Viorica Marian, who is a Sundin Endowed Professor of Communication Sciences and Disorders. And we also have Dr. Sarada Rochana Vipada, who is a postdoctoral fellow at Northwestern University. They will both be speaking on culture at play, a cross-cultural and cross-linguistic comparison of parent-child communication. Take it away. I think you're both muted. Okay.
Yep, we are good now. Thank you so much. It is an honor to be here and to hear everyone's presentations and learn about this interesting work. So as many of you are aware or may know, there are over 7,000 languages spoken in the world, but only speakers of a very small subset of those languages are included and represented in basic and clinical research. So these are usually populations referred to as weird populations. Weird stands for Western, educated, industrialized, rich, and democratic nations. As a result, speakers of most of the world's languages are not really represented in research. Not only that, but most of the speakers that are studied are monolingual, which further leaves out the majority of the world's population. It is known that more than half of the world's population speaks two or more languages. It is very common in countries all over the world to grow up bilingual or multilingual from an early age and then later acquire additional languages throughout one's life. Even in the United States, where monolingualism has been considered the norm, the number of bilingual and multilingual speakers is increasing. In the past 4 decades, it has more than doubled, and it is estimated that more than 1/5 of American households speaks a language other than English at home. In some states, as you can see on this map, those numbers are even higher. So in states like Texas, New Mexico, Arizona, California, Florida, we can see that the proportion of bilinguals and multilinguals is quite high. And yet these individuals are not included in research, which as a result leaves our understanding of human linguistic and cognitive capacity at the minimum incomplete, but also most likely it gives us an inaccurate understanding of how humans process language, of human cognitive capacity, human cognitive abilities. So increasingly, there is an understanding of the need to include linguistically diverse populations, to study speakers of two or more languages. We at Northwestern for over 20 years have been conducting research on the linguistic, cognitive, and neural consequences of bilingualism and multilingualism, looking at how speakers of two or more languages or speakers of different dialects and of a variety of linguistic experiences process their environment, their sensory environment, how they remember things, how they learn language, how they make decisions, how their brain functions. We use a variety of methodologies like eye tracking, EEG, fMRI, mouse tracking, computational modeling, to really get a deeper and more understanding of language and cognition and the brain in humans. Not only that, but one of the main things we train our students on is to be able to communicate about science to a broader population, to distill research findings in a way that's accessible to the general audience. Most recently, this includes the 2023 book, The Power of Language, which is written for a popular audience and is being translated into over a dozen languages around the world, and brings to the general audience the science, the psycholinguistics of language in populations who vary in linguistic experience. One of the projects we conduct in the lab is on language development and how children grow up with two or more languages. Today, we'll present some of that research focusing specifically on parent-child interactions. We're interested in how parents interact with their children and how children interact with their parents in countries and languages other than the United States in English. And not only that, but we are looking at how bilingual parents and children interact with each other across languages. So we're interested in whether when bilingual parent-child dyads interact, when they switch their two languages, if their interaction style changes as well. And if it does, where exactly on the continuum does it fall? Does it change depending on the language they speak? Is it an amalgam sort of in the middle between the two monolingual groups, or is one style adopted? We look at various tasks. So in this particular case, we have 4 tasks: child narrative, book reading, toy play, and autobiographical reminiscing. And I'll let Pink tell you more about the methods and the results.
Yeah, so as Dr. Marian has mentioned, we have 4 different tasks in this study. So the first task is this prompt and reminiscing task, where the objective of the task is for the moms and the children to reminisce with one another about personal experiences. So we gave them a set of 11 word prompts to use as topics of conversation. And basically, they were asked to talk about all these topics. And so in our study, monolinguals were given just one set, and they were asked to interact with one another in the language that they spoke. Bilinguals received both sets, one in Thai and one in English, and the language of order of language was counterbalanced. And so for now, we're going to show you the results from this task. We saw these 2 distinct conversation styles in the 2 cultural groups, namely the low elaborative and the high elaborative styles. And we found that essentially that the Thai dyads adopted this relatively low elaborative style. And one of the examples of the linguistic measures that they use was request for repetition, which is this strategy of eliciting information from the child, but not necessarily adding new information, just sort of getting them to repeat what they said. On the other hand, American dyads were shown to use, mothers in particular were shown to use more extensions. So they took what the child said and then added new information. And so that's characteristic of a high elaborative style. In the second task, the book sharing task, we use these 2 wordless picture books, Frog, Where Are You? And Frog Goes to Dinner. And these 2 books are commonly used in narrative research. They are picture books, so there are no words, which allow us to use it with a variety of cultures and languages. And so mothers and children in our study were asked to look at the pictures and tell stories as they normally would. In this task, we also found these 2 distinct conversation styles, but specific to the book sharing task. So we found that the Thai dyadic interaction, mothers tended to adopt this storyteller style, and this is characterized by greater use of attention directives compared to their American counterparts. So they were directing their children's attention to whatever they deemed important. And so the mothers or the adults in general in Thai culture would take the lead in telling the story. Whereas on the other hand, American mothers adopted a relatively more story builder style, where they would affirm what the child said in order to encourage participation. In the third task, toy play task, we gave them these farm animal figures to play with one another, and they were free to do whatever they would like with them. And so we found these, again, contrasting styles. The Thai dyadic interaction was more adult-centered, so we saw a lot of repetitions on the Thai children's parts, more so than their American peers. So they would repeat after what their mothers said. On the other hand, the American dyadic interaction was more child-centered. So we found that American children use more negative feedback than their Thai peers. So they felt comfortable to give feedback, and particularly when they disagree with their mothers. And so to sum up, we saw that Thai dyads adopted low elaborative, storyteller, and adult-centric styles, whereas American English monolingual dyads adopted high elaborative, story builder, and child-centered styles. So now that we've established these two sort of cultural differences in monolinguals, we wanted to see if we would see these patterns show up in bilinguals. And so, as Dr. Marion has mentioned, we have these potential predictions. The first one being that they could potentially switch between their two styles, or that they could be somewhere in the middle, or that they could just resemble one of their monolingual counterparts. So now we're going to show you the bilingual results. In the reminiscing task, we saw again this low versus high elaborative style, where mothers, when speaking in Thai, they were more likely to use expansions, so grammatical rendering of what the child said, making it more adult-like, so almost as a correction, but not necessarily adding new information. And then on the children's part, we saw that bilingual children were more likely to give negative feedback when speaking in English compared to Thai. So this is sort of resembling the English monolingual children. And so we see this contrast in the interaction styles. In the book sharing task, we also saw resembling what we saw with the monolinguals, where when speaking in Thai, mothers tended to lead and sort of tell the story. So again, they would use these sort of expansion techniques where they would grammatically model what is correct for the children. But on the other hand, when speaking in English, they were found to use more affirmations, so sort of encouraging child participation. So you see these two different styles when they switch between their languages. And we also saw adult-centered versus child-centered styles in each of the languages. So when speaking in Thai, the interactions tended to be more adult-centered, where the parents or the mothers would tell the child what they wanted to do with the toys. But on the flip side, you see the exact opposite pattern here, where when speaking in English, children were more likely to do this, right? And then we also looked at nonverbal communication. For the sake of time, we won't be able to go into this, but happy to answer any questions at the end. But to sum up, we saw cross-linguistic differences in bilingual mothers and children's conversation styles. When speaking Thai, mothers adopted low elaborative and adult-centered styles where they fostered interdependence and reference. As a consequence, children took on a more passive role. When speaking in English, mothers adopted high elaborative and child-centered styles, which fostered independence and autonomy. And when speaking in English, children, as a result, took on a more active role. And now I'll send it back to Dr. Marion.
So just to also make it clear, this is a part of a larger project where we're collecting data in other countries as well. We're currently testing a group in Taiwan, speakers of Mandarin, both monolingual and bilingual Mandarin English speakers, and also bilingual Mandarin English speakers in the United States to compare. So in all of these studies, we have usually 4 groups: a monolingual English speaking group in the United States, a monolingual English speaking group abroad, and a bilingual speaking group in the United States and abroad, to really try to dissociate and compare linguistic and cultural groups. So this is, again, part of a larger project that hopefully will give us a better understanding of how parents and children interact with each other across languages and cultures. But from what we have seen so far, it does seem that bilingual caregivers scaffold children's linguistic skills differently in each of their 2 languages, in ways that are consistent and informed by their cultural background. As a result, bilingual children often exhibit different communicative patterns in each of their languages when they interact with their parents. These differences can be seen as early as the age of 4. So there are multiple studies that show that bilingual adults can differ on many dimensions when using their native language versus their second language. They differ in decision making and the memories they access, even in their personality traits sometimes. But we can see that those differences emerge very early in life, even in preschoolers, suggesting that language can cue these culture-specific behavioral norms from a very early age. Although this is only very early work, and we are in the initial stages of this project. This work is funded by a NARO R21 grant. We do think that long-term implications of these studies will be relevant in educational settings and in clinical settings for speech language pathologists, for medical professions, in terms of informing our understanding of how the linguistic and cultural backgrounds of speakers of different languages inform their approach to accepting or declining clinical services, how they interact with clinicians. We do see that bilingual patients tend to make different decisions in one language versus another in other related work, basically suggesting that it's important to expand research focus to include linguistically and culturally diverse populations across the lifespan, from early childhood to later in life. And we have time, a few minutes for answering questions and having a bit of a discussion on this. But I do want to thank the funding, the current lab members, and the previous students and collaborators in our lab. And again, acknowledge the fact that we talk about this research and other work in the power of language.
Excellent. Thank you for this lovely presentation. There is a question in the chat, and I'll invite everyone in the audience to continue to enter your questions into the Q&A box should you have some. The first question is from Amelia Nor Oshiro. What hypothesis would you investigate in terms of communication differences between various generational statuses, first, second gen immigrations, etc.?
It's an interesting question, and as I mentioned, this is very early work, so we really don't know yet much about this area. So there is just so much work to still be done. So if you're talking about heritage bilinguals, is this what you're asking about? Bilinguals who grew up in their adopted country and speak a second language as a heritage language in their home? If that's the question, that we would expect them to show similar changes between their native language and their second language, and to switch communication styles depending on which language they are using. I think children are very perceptive in who they interact with, and they're able from a very early age to adjust their communication style based on their interlocutor, based on the language they are using. I don't think that for heritage bilinguals, the patterns of result would differ in young children. If you are asking about generational differences, for example, in older adults, then we don't really know what is likely to happen there. I'm thinking that the likelihood for older adults would be that their most used language and most dominant language is more likely to carry on to the cultural patterns that are used in their native language to carry through into their second language. Right now, we're looking at this population that we studied are bilinguals who are equally proficient in both languages. So we test them on cognitive abilities, linguistic abilities, to make sure that they're really balanced bilinguals. They grew up with both languages. It's not clear whether this pattern would hold for people who grew up with one language and spoke it for a long period in their life and then later acquired their second language. For those populations, it's quite possible that the stronger language, the linguistic and cultural norms of their stronger language will be adopted to a greater extent when using their second language.
Excellent, thanks. And we do have one more question in the chat, but we're just about ready for the break. So what I'll do is read this question out, and if either of you could just answer that live so that the audience can also see that, that would be excellent after you take your break, of course. So the question is, can you speak to the interaction of parent, gender, and language use, particularly in families where one parent exclusively speaks language A to the children and the other parent exclusively speaks language B to the children? How might gender roles and norms interact with languages to impact linguistic patterns and conversational styles? That's
This
the
is a great,
question.
this is a great question. So we actually did look at gender, the gender of the child, and we do see that the child's gender makes a difference in how parents interact with their children. We haven't compared the mother's and the father's gender, primarily because of their cultural differences in caregiver status and who takes care primarily of the child, especially in non-Western nations. But this approach of what's known as one parent, one language approach has not been studied in this particular setting. There is no reason to think that the results would differ if the father is a caregiver in the same way, so interacts with the child extensively and is a bilingual caregiver. We would expect the patterns to be similar to that of the mother. Do you want to speak a little bit to the differences depending on child gender?
Yeah, so we found that child gender does have an influence on how the moms scaffold or talk to the children. So in that girls are tended to be expected to be more elaborative and sort of have these connections with their social groups. So there is this tendency to talk more and ask more questions and talk about feelings and things like that. Whereas boys may be expected to be more independent. And so there is not less of an expectation to have this sort of very loquacious or sort of, extended conversations about different things. So we did see that in our work as well.
And of course, for this presentation, we just picked a couple of behaviors from each task, whereas in reality, we coded for all verbal behaviors, including nonverbal communication, which also tends to differ across native and second languages in both parents and children. And they do switch their nonverbal communication across languages. So for a more in-depth dive into this research, please take a look at our papers.
Excellent. That's a great transition. Thank you so much to all of the speakers for this excellent session on communication to kick off the festival. We are going to go into a break.
Okay, it is 12:40. So I think it is time for us to move on to session 2. I'm assuming everyone can hear me. I am Dara Blackman-Demner. I am at the Office of Behavioral and Social Sciences Research here at NIH, and I am delighted to be moderating this session, which will be focusing on stigma. As before, I will introduce each a speaker, and they will have about 15 minutes for their presentation, a few minutes for Q&A, and then we will wrap up. So I'm really excited to bring you our first speaker, Dr. Lisa Boleg, Professor, Department of Psychological and Brain Science at the George Washington University. And I will turn it over to you, Dr. Boleg.
Thank you. Good afternoon. I'm really delighted to be here. I'm going to be talking about what I see as a sort of necessary shift in what we talk about when we talk about intersectional stigma, namely the need to shift it from sort of internalized stigma of Black, gay, bisexual, and other men and men who have sex with men towards healthcare providers. And so just a little preview of where we're going. I'm going to give a general overview, really quick overview of HIV and PrEP inequities for Black, gay, bisexual, MSM. I'm going to use the acronym because it's just easier, GBMSM. And then I'm going to talk a little bit about this need to reconceptualize stigma. And then I'm going to talk about how we have integrated these sort of reconceptualized idea of intersectional stigma into an NIMH-funded R21, which was developed to design measures of multi-level intersectional stigma for Black GBMSM. And then I'm going to leave you with 3 takeaways. Okay, so just the general takeaway is that when we're talking about Black GBMSM, what we find is despite all of these amazing sort of technological advancements in HIV, that Black GBMSM are still sort of lagging behind in terms of access to PrEP. So what we find is that Black men account for roughly sort of 3/4 of all Black people with HIV, and I'm talking new HIV cases, and that we still see disproportionate rates among Black gay, bisexual men, and men who have sex with men, who are accounting for sort of 82% of HIV new diagnosis. And the chart on the right shows you that despite the availability of PrEP, pre-exposure prophylaxis, which is really effective at reducing HIV infection, we see that Black men have the lowest rate of uptake of PrEP. So 27% compared with about 42% for white men. And yet this is happening within the midst of empirical evidence showing that overwhelmingly that Black men are engaging in HIV protective behaviors, that research shows that they report fewer sexual behaviors, less condomless anal sex, they report more condom use, and greater likelihood of HIV prevention behaviors compared with their white and Latino counterparts. And yet, still, we look at a really effective prevention tool like PrEP, and we find this lag. Now, there's sort of two key points about PrEP that I want to highlight. The first is just how effective this is. This is data from the CDC showing that for oral PrEP, the effectiveness of this in reducing HIV is roughly 99%. The other important thing to stress is that any licensed healthcare provider can prescribe PrEP. PrEP is not something, I say this all the time, PrEP is not something that you walk into the CVS and pick up like condoms. It has to be prescribed by a provider. And so this is a really important group, healthcare providers and the healthcare settings in which they provide care to look at stigma. So over and over, what we're seeing in the literature are studies such as this. This is a 2019 study, that showed comparisons of Black gay men, white and Latino. What's notable is that everybody had access to insurance. And what you'll see is that on PrEP awareness, discussing PrEP with healthcare providers and using PrEP, Black MSM ranked the lowest of all of the groups. Latino men weren't much better, but over and all, we see these sort of racialized inequities in PrEP. This is more data showing, again, the same thing, right? So that we'll see in the bottom row that 25% of all gay and bisexual men in this same survey without HIV, 25% use PrEP compared with with 19% of Black MSM. So what's happening? So if we look at stigma, and if we think about, and there's so many different ways that stigma has been conceptualized in research, if we go back to sort of Irving Goffman's original reconceptualization of stigma, stigma is very much this sort of attribute of the person, right? It's almost like this, this scarlet A that you're born with. In the preface, Goffman defines stigma as the individual who's disqualified from full social acceptance and is reduced in our minds from a whole and usual person to a tainted, discounted one. So the problem here, as I see it, is that this conceptualization of stigma very much puts stigma in the person. It's almost like this sort of birthright that people have. And so our work is very much formed of sort of really transferring stigma from this internalized individual view to the outside, which is where stigma comes from anyway. So there are many people other than myself who have criticized these sort of traditional definitions of stigma, these sort of individual level. And some of the criticisms of these definitions are that, one, when people talk about stigma, the definitions are always vague. Sometimes there's no definition at all, or there are like too many definitions that, as I've said, it prioritizes the individual level exclusively. And so when we're talking about Black GB MSM, it's typically about, their internalized homophobia and their internalized racism, for example, without attending to these external factors beyond the level of the individual, such as racism and heterosexism and misandry, particularly Black misandry, which is a sort of this hate of Black men specifically. If we're talking intersectionally, those are often sort of not accounted into definitions of stigma. Again, it's often focused on the person who is the target of the stigma and very little attention to stigmatizers, which is something that I'm interested in focusing on. Why? Because you can develop interventions, particularly when we're talking about healthcare providers. Stigma is often used synonymously with discrimination, and so so there's a sort of conceptual confusion about what we're talking about and what we're intervening against when we talk about stigma versus discrimination. And one of the most important points, certainly from an intersectional perspective, is this absence of attention to power and the role of structural inequality. And these critiques are not new. Parker and Eggleton, in their 2003 piece, talked about the role of power and really identified, they were speaking mostly about, in this piece, about HIV stigma, but they really talked about the need to reframe how we understand stigma and discrimination as social processes that can only be understood in relation to broad notions of power and denomination. And this fits really well with intersectionality, because intersectionality is a critical framework that talks about how people's individual level experiences, so the experiences that Black GBMSM recount with stigma, reflect these sort of larger interlocking systems of racism and heterosexism and misandry, as I talked about earlier. So a bit about intersectional stigma. Intersectional stigma is this term that Michelle Tracy Berker coined back in 2004 when she was doing her doctoral research, and she was looking at women living with HIV and looking at their political activism. And what's important about this definition is that she didn't focus on identity. She really coined the term intersectional stigma as describing how stigma, and she was looking specifically at HIV stigma, but how that aligned with the structural realities of race, class, and gender. And so it's really an ideal term for sort of understanding the context of HIV prevention for Black GBMSM. And so in 2018, NIMH came up with concept clearance for the term of intersectional stigma. But one of the issues that I've critiqued about their definition is, you'll note this intersectional stigma conceptualizes multiple stigmatized identities. And I think this is not the way we need to be thinking about stigma. We really need to be thinking about it as a multi-level concept that involves individual level stigma, but also stigma at the community level and at the structural level, which is something we attempted to do in our research. This is a paper on which I'm a co-author with Catherine Quinn, sort of just talking about how the intersectional stigma that Black men face. And in this article, they recount all of these different barriers to care, particularly with healthcare providers, and how healthcare providers treat them, and all of these sort of assumptions, for example, that they have lots of sex partners or they're not going to take PrEP, as an example. And I want to be sure to highlight this. This is the NIMH sponsored AJPH, American Journal of Public Health supplement that we did on intersectional stigma that came out in June 2022. And my co-guest editors were Sanisha Dale, George Ayala, and Carmen Logie. So I really encourage you to check this out. Now, I've been really critical of intersectional stigma and whether this is the right term in the context of HIV. And in particular, this is an article that I have in that special supplement where I highlight sort of three problems with how the field has been using intersectional stigma. One is, this lack of clarity, as I said earlier, about whether we're talking about stigma or really are we talking about discrimination. That we often talk about stigma in the healthcare context as if there are not instances that we know and empirical evidence showing that healthcare providers themselves, who are supposed to be serving Black GBMSM, often have lots of their own stigma, and that's usually not a focus. And then again, obscuring the role of power and social structural inequality, which is just vital to any intersectional perspective. And so this is something we've sought to include in our work. So this is our 21, and as I said earlier, the goal of it was to develop these multi-level measures of intersectional stigma, and our participants were Black men in Jackson, Mississippi, and Washington, D.C. It was in response to this request for applications put up by several institutes at NIH. These are my co-investigators, Ana Maria Del Rio Gonzalez from GW, Shanika Hull, who was at GW, is now at Rutgers, and Tamara Taggart at GW, and Paul Burns was our co-investigator at the University of Mississippi at their medical center. And so we were very much interested, as I said before, in understanding these sort of interrelated processes, social processes. And so we sought to develop measures by at the individual, community, and social structural level. These were men who were 15 to 34, identified as GBMSM. We did individual interviews with them, cognitive interviews, and then we developed a validated measure. And so in the initial stage, these were some of the things that men said in the interviews about why they weren't on PrEP. Lack of access, didn't know where to get it, white privilege grants, white men access that GBMS, that Black men simply don't have. And so we developed the measure from the ground up, and we partnered with HBTN 096, that HIV prevention team, and they sampled our pilot measure with 422 men in Black, gay, bisexual men in Dallas, Montgomery, and Greensville, North Carolina, and found that our alphas were really amazing, that our scales that we had developed from Black men's experiences really captured a lot of the sort of experience that they report about structural racism in healthcare systems, for example, or stigma from their religious communities. And so the next phase for us is to pilot the entire measure. The HBTN 096 team only did a subset of measures. And so 3 takeaways. There's a dire need, we think, to embrace critical frameworks such as intersectionality that center Black men's experiences and really allow us to understand their experiences with structural level discrimination. The importance of reconceptualizing stigma to understand where the responsibility for the problem lies. This is something that Liz Sayce, who is a disability activist, talks about. She says that, if we sort of center, if we're not clear, we end up putting the problem and the responsibility for the problem in the population, in this case, Black men. And that since you can't get PrEP without healthcare providers, it's really critical that we focus on their stigma and developing interventions for that group, and that should probably be the primary focus of PrEP interventions, and not just sort of re-stigmatizing and focusing on Black men and their internalized stigma. Thank you.
Fabulous, Dr. Bullock. That was so much information and you got through it like perfectly on time. So we do have some time, a few minutes for questions. As a reminder, please place your questions in the Q&A. Any questions for Dr. Bullock? Okay, so we have the first question. This is a great measure. Do you think it might be applied to other health issues for intersectional stigma, for example, mental health issues among Latinos?
I think that we would need to sort of develop with the population. I mean, I think that's really important. Intersectionality always directs us to the specific and particular concerns, to use a quote from Kimberly Crenshaw that I use all the time. And so we would want to know what the specific concerns are, or types of intersectional stigma that Latinos, and then again, it would likely be different for Latinas, Latinx, non-binary and transgender people, Latino men. And so I think I would strongly advocate that when we're developing measures of intersectional stigma, that we develop it from the ground up with those populations. But I think, yes, I think the concept can be applied to other health conditions beyond HIV for certain.
Wonderful, thank you. Don't see any other questions at this point. Did you have some quotes or other things that you wanted to share? We have like another minute or two.
I have a fabulous two minute 30 video, but it might be too long. But I can tell you what the video I was going to show you about. It's not as good as me telling you about it, seeing it, but it's basically a video that Dr. David Malebranche, who's an infectious disease physician who is now at Gilead Sciences. It's his address to the International AIDS Conference in 2018. And he was talking a lot about stigma in the context of Black gay men seeking HIV prevention. And he used the metaphor, he had an image of Gordon Ramsay, and he asked, why am I showing you Gordon Ramsay, who is, the critic on TV? I've never seen his show, but he's the one really mean, goes into restaurants and cleans it up. And he said that, if you went to a restaurant and then if you opened a restaurant and then people stopped coming, you wouldn't put the blame on the clients. You would start thinking about, is it the food? Is it the decor? Is that, all of that. And you would really invest a lot of time and money. And he says, we don't do that in HIV. We put the problem in the group, which is further stigmatizing. We don't think about, well, what about the stigma of the healthcare providers? What's on the walls? How is the context stigmatizing? And so he just used, it was just such a beautiful summary of how we let healthcare providers off the hook when we're talking about stigma. That's it in a nutshell.
That's fabulous. And that we got a bunch more questions, so we'll see if we can get to all of them. But the first one actually is a great follow-up to what you were just talking about. Are there any empirically supported interventions to reduce stigmatizing in providers?
Not that I am aware of. As you can imagine, one of the challenges, because I have a team where we wanted to develop and test such an intervention. One of the problems is access to healthcare providers in the first place to even sort of develop and test the intervention. And so most of the interventions that I'm aware of have been conducted with trainees, for example.
Okay, and I guess a follow-up about intervention here. Could there be differences in intervention between individual group stigma consciousness versus experiences of discrimination?
Could you ask that again?
Yeah, this is from Amelia Nor Oshiro. So hopefully we're understanding this correctly. Could there be differences in intervention between individual or group stigma consciousness versus experience of discrimination? Perhaps it's asking about that difference that you alluded to between stigma and discrimination and how they might be differently targeted in intervention. I'm not.
Yeah, I imagine so. I guess when I think as an applied social psychologist, when I think about the term that's most useful for intervention in this context, I really think it's focusing on discrimination, right? So why, regardless of what that person's stigma is, what are the barriers of the person with the power to prescribe that are constraining their ability to follow CDC guidelines when we know that that PrEP is so effective? And so as somebody interested in intervention and prevention, much more interested in that question than the individual level stigma experiences of the patient. I'm not sure if that answers it, but that's sort of how I think about these issues.
Wonderful. Okay. We do need to move on. Thank you again, Dr. Bolig. Really appreciate you and your presentation. And now I am going to move on and introduce Dr. Sean Young, Professor, Departments of both Emergency Medicine and Informatics, and the Executive Director at the Institute for Prediction Technology at UC Irvine. Welcome.
Thank you. Thank you for having me. That was, can you hear me? Yep.
Yeah.
Thank you. Yeah, thanks so much for having me, OBSSR and NIH for funding this work. It's nice to see a number of different people from program who are here from the different institutes. Today, I will be talking about stigma and misinformation related to opioid use disorder. And just pull up the slides. Yeah. Can you see the slides?
Yes.
Perfect. Okay. So just stigma and misinformation are separate but related items that we'll go over. As a background on opioid use disorder, there were 70,000 deaths that occurred in 2020 due to overdose. As most of you know, this epidemic has just been increasing and has turned to being caused primarily with fentanyl more recently. Opioid use disorder causes significant impairment and distress. There are a number of treatments that are available for it, including methadone, buprenorphine, and extended release naltrexone. But for a number of reasons, the uptake of those treatments is suboptimal. And one of the reasons behind that is because of stigma. People who are suffering from opioid use disorder are often discouraged because of stigma from taking treatment. And however, social media and online communities might be a way of combating that stigma, and helping people to be able to prevent OUD and be able to seek and get on treatment. Some interesting things that we found. So in interviews with patients with opioid use disorder, we found that the patients would rather receive information about treatment and about OUD from other patients, from other peers, rather than from healthcare providers. That was surprising to us when we found that, but provides a lot of support for the potential of online communities. Face-to-face support groups, for example, like NA, these support groups can be both time intensive and they can be stigmatizing as you show up and other people can see you in person. Whereas with online communities, people can remain behind their avatar or behind their picture and be able to have potentially a less stigmatizing experience that's also easier for them to attend. Online social support groups may therefore be more convenient, acceptable, and less stigmatizing for those patients. So online communities are already being used by people with OUD, and they're being used for all kinds of different things where people can come together and discuss their pain, because pain is often a precursor to opioid use disorder. And there are a number of examples of these online communities. We've run our own, which I'll get into in a little bit, on Facebook, one of them called Harnessing Online Peer Education Study. One of these currently funded by NCCIH. And there are a lot of discussions around opioid use disorder around this. There are also Reddit opioid recovery groups, for example, one with more than 5,000 members and discussing all kinds of different issues. Here are some examples on the right of some of these communities and their conversations of people talking about fentanyl and trying to quit fentanyl or trying to quit heroin and what they did. And so these discussions, people share all kinds of very personal information, questions, supportive information, as we'll get into a little bit, sometimes misinformation, and which this information can both potentially create stigma and misinformation, or can reduce stigma and misinformation depending upon how they're used. Now, researchers like myself and many others on here, researchers can use data from these online communities and social media for this work. So we can learn about patients with OUD and what are their needs, what are their struggles in dealing with OUD and potentially treatment, and how to improve access to treatment for them. And we can also learn how they discuss their pain and opioid related issues. So here's an example from an online community study that we did a few years back. This was funded by NIDA, and it was a social media online community support group among chronic pain patients at UCLA. And this was a subset of those patients who were in the online community. This was a randomized controlled trial that took place over 12 weeks through one of these HOPE online communities. The HOPE communities it's a peer-led intervention wherein the control group, there are no peers, just patients with opioid use disorder, or in this case, chronic pain on opioids. In the intervention group, there are peer leaders who are effectively managing their chronic pain on opioids safely, and they've been taught the science, the psychology of how to engage with other patients, with other strangers, and build a supportive community. And then over that 12 weeks, they just organically talk with each other. So you can see, compared to the control group, the intervention, this peer-led community leads to a lot of engagement. A lot more conversations happen within the 12-week period compared to the control group, about 8 times many conversations. And you can see the topics they discuss. They'll talk about their physical health status of the pain they're experiencing. They'll talk about mental health. They'll talk about their non-medication treatments that they've tried, alternatives. They'll talk about medications. They'll talk about substance use, how to cope, different types of social support, and experiences with addiction. So they will discuss all kinds of personal things with each other, even though they only came together through this study where we invited them to join this community, and they didn't know each other. And people said that some of the comments were just from within 3 days. They said, wow, I am just glued to this group. I've never before been able to be around people who are experiencing what I'm experiencing and be able to talk to them and share with them. It is just such an experience to be able to do that. Now, in addition to data on what patients are talking about, you can use, our team has used internet search data to be able to predict opioid-related outcomes, in this case, future emergency department visits for heroin. So this was a study looking at, we found Google searches for opioids, that in cities where there were spikes in Google searches for opioids, that predicted future spikes in those cities for emergency department visits for heroin. So you can use social media data, you can use internet search data to get an understanding of people's psychology, of what they might be doing online, and use that information to predict future needs, and in this case, emergency department heroin admissions. In a follow-up study, we also incorporated Medicaid data and found results in being able to predict over a number of years, being able to predict opioid emergency department visits. And this includes being able to track the switch from different types of opioids that have occurred, for example, from prescription opioids to heroin, which is typically difficult to model, and this worked very well in being able to model it. Here are examples of, within that study, some of the top drugs that we found that were discussed or prescribed, along with, in the second column, this for each state, the top search terms on Google. So you can, with these types of research studies, you can be able to learn about which drugs and across which states, or which opioid-related terms are people discussing or searching for on Google, on the internet, to be able to better understand people's psychology and their needs. Social media and online communities can, we've talked about some of the benefits, and especially among researchers, but they can also carry a lot of misinformation. So that's something that is really important, where we need to be aware of both misinformation that's happening because of the power of social media and the amount of people who are on social media and online communities and searching for issues with their health problems, as well as often trying to drive others to share the same treatments that they have, or maybe there are people attempting to market certain treatments. There's misinformation and there's disinformation, where people are maybe actively trying to spread misinformation for various reasons. So it's really important that we as public health and as researchers are aware of misinformation on there, are trying to combat that misinformation, trying to figure out how misinformation may be being spread, and especially as those of us in health informatics, we can develop new ways of detecting misinformation using different technologies like artificial intelligence. One example, so I haven't seen any studies in the opioid space relating to detecting or reducing misinformation around opioids. But one example, something that we did in our on our team, we both around COVID, we developed some machine learning and artificial intelligence models, first to identify misinformation around COVID. And we have released a data set where others can be able to use that information, use the data set where we've collected around misinformation. And then beyond that, beyond detecting misinformation, we also developed a study to be able to reduce misinformation. And this was another HOPE online community where we had peer leaders. Here, these were individuals, healthcare workers, who had not been vaccinated and who had not been vaccinated. And we had an online community, and we were trying to reduce the misinformation around COVID-19. And we found that our online community helped reduce that amount of misinformation greatly. And you can apply these types of peer-led approaches to helping to reduce stigma and misinformation around opioid use disorder as well. So lessons learned, online communities and social media are widely used by people who use or misuse opioids, often with large amounts of misinformation. Researchers can use these technologies and data to monitor views as well as to intervene. And more research is needed in this area to learn about best practices, and especially the ethics of understanding and intervening prior to implementation. And as with all of our work in these interdisciplinary areas, it's a team science approach, so many involved, and want to thank everyone for their help and great research and being involved.
Wonderful. Just on time. Thank you, Dr. Young. So again, a reminder, please place your questions in the Q&A. We have about 5 minutes for questions and discussion. Give folks a minute to. Well, I'll jump in and maybe give folks a minute to think. Just going back to your last slide about future directions, maybe can you tell us a little bit more? I think, okay, now the questions are coming in. But I was going to ask about particularly around the ethic, I think your last bullet point talked about, I'd be curious to hear, to hear your thoughts or how your team is thinking about sort of that piece of this type of research.
Yeah, so for moving forward, one thing is looking at within social media content. We've looked a lot around predicting HIV cases, predicting HIV-related stigma, and we are looking at similar things, looking at people's posts on different social media sites. So whether it's on Twitter, on X, and looking at natural language methods, or on Instagram and looking at images and videos, trying to use more artificial intelligence methods to monitor and predict opioid use and stigma and misinformation. And and as well as intervening. We've been refining our methods for the HOPE intervention, and initially we had used those on Facebook, and then we built our own online community because patients, actually because of the stigma, opioid patients specifically had requested a different community other than Facebook that we started working with a number of years ago. And so we have that available. And now we're working on adapting these communities to Instagram and to Discord and newer technologies.
Great, thank you. So a couple of questions have come in about sort of strategies, I think both generally as well as, potential research strategies to combat misinformation or disinformation. Do you have any thoughts about that?
As just like Dr. Boleg, my background is as a social psychologist. So I see myself an applied social psychologist, and that social part is important. And so that's why our HOPE online community it's peer-led intervention. So one, it's not top-down in the sense of researcher, clinician telling others what to do. We purposely try to make it flat or non-hierarchical. It's exciting because the peers themselves are the ones delivering the intervention. So I think with any of these methods where we are trying to, with prevention and treatment and behavior change, it's really important to empower the patients who are succeeding and to give them the training in psychology of how do you reach out to others, and what is the social marketing, what are the methods of spreading the change that you're already doing. You are a role model. Let's empower you as a role model to help others. And so with that psychology, it doesn't really matter what the outcome is, what the disease area, whether it's HIV or substance use or opioids, or whether it's misinformation or trying to increase testing or treatment. The psychology is the same in terms of finding people who are successful and well-liked, well-respected, and peer leaders, and then providing them with the science and the tools for them to be able to help others. And it's the same, then we just adapt it to the features on certain technologies, because some technologies allow, let's say, chatting, where others you can post videos or things like that. So we just figure out how to adapt that science based on the affordances of the technologies.
Wonderful. And that is, I think, a great way to end. We need to move on now to the final speaker on this panel. So thank you again, Dr. Young. And now I'm going to turn it over to Dr. Emily Wakefield, who is a pediatric psychologist, the Division of Pediatric Psychology and Pain and Palliative Medicine at Connecticut Children's Hospital, as well as Assistant Professor of Pediatrics at the University of Connecticut School of Medicine. Welcome, Dr. Wakefield.
Thank you so much. I really appreciate the invitation to be here. As I was introduced, I'm a pediatric psychologist at Connecticut Children's, and I'll be presenting on a paper of a mini review that was written by myself and several colleagues that dives into pain-related stigma as a social determinant of health in diverse pediatric pain populations. I originally got interested in this topic area as a pediatric psychologist embedded in a pediatric chronic pain clinic. I think a lot of people are surprised that chronic pain can exist in children, but actually it occurs in every 1 to 4 to 5 child or adolescent could actually have a chronic pain condition. And as we see them in our multidisciplinary chronic pain clinic, I was struck by the repetitive message that families came in with, that others did not believe their pain, felt like that their child was making up their pain. And they were even getting these messages from medical providers. And also to note, a lot of our chronic pain patients that we were seeing in our tertiary chronic pain clinic were largely white and private insured. So they were experiencing this type of stigma. I had a deep appreciation of what those with marginalized backgrounds or marginalized populations were facing when it came to bias related to their pain reports. And that was what really inspired this mini review. Oh, okay, there we go. I don't have any financial conflicts to disclose. I am appreciative of NIAM's support of my K-23 that focuses on pain-related stigma. And I'd like to acknowledge the traditional stewardship of the land in which I work and live by the Indigenous people and their ancestors presented here. I acknowledge that I'm a settler on this unceded land, which does not absolve me of ongoing colonialism. I also acknowledge that I am a white cisgender woman, and I strive to use my privilege to commit myself to the understanding and mitigation of systems of oppression that have impacted Indigenous people and other populations that are marginalized. As I present on pain experiences amongst marginalized children, I invite feedback if I present in a way that perpetuates harm, that I can also increase my awareness of my own biases. This is the paper that I'm going to be referring to. I have to say that it's very in-depth, and I will try my best to do it justice. It was presented in the Frontiers in Pain Research, and here are these phenomenal women researchers that I co-authored the paper with. It was a special issue of Women in Science, and I'm very proud of the work that we were able to accomplish. If I cannot answer a question, I will make sure that I'm able to get the answer from maybe one of my colleagues if it's within their area of expertise. I appreciate Dr. Boleg's introduction of what stigma is. I think she did a phenomenal job sharing that it's not just internal. We have to look at it interpersonally and societal and systematically as well. But just to reorientate for this presentation, it reflects a societal devaluation of a specific attribute an individual possesses, and that can range across a lot of different attributes. And when it comes to health-specific stigma, there's different health conditions. I mean, HIV was already presented on beautifully, but physical disabilities, obesity, and this current presentation is really going to be looking at the intersectionality of pain-related stigma and marginalized within marginalized populations. And here are some of the marginalized groups that I'm going to be highlighting in this population, although there's more out there that we could spend time on as well. You know, the intersection of how pain is experienced or either believed or not believed when met with marginalized race, ethnicity, lower socioeconomic status, and gender. There is more to be done in the LGBTQAI+ community in pain-related stigma. There's not a lot out there, so when I do present for this presentation, I'll be using more biological sex and those binary categories of girls versus boys, but want to indicate that there is LGBTQAI+ pain-related stigma that is evolving and growing in popularity, but there's just not enough out there for me, unfortunately, to present on today. The adults are further along in their stigma literature and research than children, so we're trying to catch up here, but this is just a nice representation of how stigma can be a fundamental cause of health inequities, can create a lot of that social exclusion. And so I think that this group did a beautiful job really sharing the different areas of health inequities that can be impacted by just having a stigmatized status and being treated differently. And again, just kind of highlighting that pain-related stigma reports that I felt that I was hearing quite often in the population I was working with of children and adolescents with chronic pain. They were coming in again, feeling that people just felt that their pain was all in their head, that no one believes them, that they thought that they were faking it, and just really pleading our chronic pain clinic to please believe their pain. And as you could imagine, if you are going from medical provider to medical provider or school teacher to school nurse, and no one is really believing this pain experience that you're having, what that must do, not only from a stress standpoint of feeling isolated and excluded, but then also how it's going to impact your pain care and pain equity. And so this just really highlights what that stigma is the lived experiences that have been described. And some of the main challenges with pain is that pain is invisible. We don't actually have an objective way of measuring pain. We can't give someone a blood test or take their temperature or do an imaging to know what type of pain they're in. We have to rely on their 0 to 10 rating scale. So we have to rely on the patient's individual subjective report. And then it's on that observer who is either going to believe them or not believe them, take them, and figure out their credibility. And that's where the stigma can occur, right? Is if someone is somehow dismissed or devalued in a way because their pain is not believed in that subjective interaction, that is where the source and that interaction of pain-related stigma can occur. And observer bias, is something that we highlighted in our mini review as some research to try to understand what might be going on, particularly in marginalized populations. Dr. Amma Kissy, who is, a co-author, give me a sneak peek, co-author of our paper, really looks at attentional bias. And so what attentional bias theoretically is, conceptualizes in the context of pain bias is, observers who are more able to attend to the behaviors of others are more likely to accurately detect pain and engage in caregiving behaviors. So a lot of the social methodology that has been used in attentional bias research is using a search task, looking at different faces in pain. And they have found some patterns where adult observers are more easily attend to male versus female faces in pain. And Dr. Amos Kissy work has looked at race, looking at adult white observers are more easily disengaged from Black versus white faces in pain. So again, with the theoretically conceptualizing that as you are more disengaged from a face in pain, you might be less likely to attend and less likely to engage in some of those behaviors that are altruistic and helpful and compassionate towards the individual in pain. Looking at more implicit, explicit bias work that has been done, this paper highlighted a study done in 183 adults that observed a videotape of a gender ambiguous child receiving a finger prick blood test. Half were told the child was a girl, half were told the child was a boy. Participants rated the male child as having more pain, and participants also indicated beliefs that girls were more sensitive to pain and more reactive, meaning that more took the boy's pain more seriously. Looking at socioeconomic status, these researchers presented adults with child school profiles, asked them to rate the child's pain across 18 different painful situations. Research showed that children with lower SES were believed to have less pain, as well as requiring less pain management compared to those children with higher socioeconomic status. And this was, repeated in comparing undergraduate students viewed 12 faces of either white or Black toddlers in pain, and to ask about pain sensitivity. And the participants showed, endorsements of Black children feeling less pain or less sensitive to pain compared to white faces. We also know that in terms of racialized individuals. There are different opiate prescription practices, even in children, when it comes to acute care settings. And so this definitely has implications to pain equity difficulties. And chronic pain, again, is something that also is a population to pay attention to, given its prevalence in young populations. There's a lot of diagnostic uncertainty. The pain system disease is largely invisible, as I mentioned before. And there's a lot of medical mistrust, not only in the experiences of not feeling believed, but marginalized populations also struggle not only with pain, but other health trust too. And so they just kind of are layered here of the stressful experiences one experiences when it comes to having pain and having a chronic pain condition when interacting with a healthcare system. Obviously, pain-related stigma is there, and that can really also lead to the undertreatment of pain, again, particularly in marginalized groups. So what does that mean on a biological level? Dr. Sarah Nelson has done some really strong work when it comes to the stress of having pain and how it can really influence the biology of the individual who's experiencing these social stressors, and really linking it to allostatic load, immune dysfunction, as well as the HPA axis regulation. And so the more stressors, especially when you experience discrimination, stigma, that can really have an impact on your physiology, and that can play into the biology. And it'd be nice if we can somehow find a biosocial marker, right? So the biology interacting with someone's social environment, and really laying the foundation of why changing the way that these others interact and our systems support individuals in pain, particularly within marginalized populations, is really important, even on a biological level. And there's still more work to be done here. Okay, so what are some of those next steps? Well, the research is scarce. When I first started this journey 8 years ago, there really wasn't a lot of research on pain-related stigma. And as you can imagine, there's even less in marginalized populations. So we really need to do more work in this area. Some of the things that I'm trying to work on right now is even developing a pain-related stigma measure, so we can understand its prevalence and impact within these populations. And so there's not even a pain-related stigma measure out there. So stay tuned, but obviously I hope that this presentation inspires some of you to perhaps go into this field. And Dr. Boleg had already mentioned this too, patient partnerships are really important, especially when you're working with a population that has been marginalized and discriminated against, not only in designing future research studies to make sure that there's an alignment and attunement with what is valued by the population, but also in the development of clinical interventions. I feel very fortunate to have just received supplemental funding for my K-23, where I am not only interviewing Black youth with chronic pain, who again, I shared, do not come into our clinic very often, and I'm curious about the systemic barriers that are creating issues, but then also develop diversity task force so that I'm partnering with families on what do we do to not only change our research practices to make sure that they're more inclusive to Black voices, but then also looking out to future work and how to, again, potentially develop interventions and where to develop the interventions based on their experiences. And again, I'm a big fan of Dr. Boleg here, as I keep on sharing, like, it has to be multi-level. It can't just be, individual based. It can't even just be interpersonal based in the dyads. It really has to be systemic also. So we really have to pay attention to all these different levels when we think about stigma and where we need to intervene. And Stagel and colleagues has this really nice health stigma discrimination framework that really highlights that multi-level need when we look at stigma experiences in health populations that I'd encourage you to look out for. Okay. And that is the end of my presentation. Again, thank you so much. And I'm looking forward to comments and questions.
Great. Thank you, Dr. Wakefield. Yes, we have about a few minutes for questions. So again, as a reminder, please place your questions in the Q&A. I see lots of applause coming in.
Thank you.
So I'll give folks a minute, and I'll just maybe to get us started. Yes, when you were talking, I mean, I see you already incorporated, much of what Dr. Bullock was talking about this morning, but I would be curious based on that and some of what she presented around sort of measure development and, thinking about, you mentioned that was maybe something that was a next step for you. So I'm just curious if you have any thoughts about kind of how to best measure pain-related stigma in the populations that you're working with.
Yeah, well, I'm so happy you brought that up. I think I sometimes get frustrated about the way that measures are developed, especially for children. Sometimes we take adult measures and we make it 8th grade reading level or 5th grade reading level to try to measure the same constructs, and we might miss the mark a bit. And so with the work that I'm doing with my K-23 is I actually used focus groups. And I analyzed focus groups and I integrated stigma theory and I developed items based on not only the lived experiences of the adolescents with chronic pain that I had in my focus groups, but then again, I also integrated the stigma theory within that as well. So the lived experiences of this population really rang true when developing not only the items, but now I'm working on the validation of it now as well. So I think sometimes we do have to really integrate the patient voice. Actually, it's essential to integrate the patient voice when it comes to measurement development, especially if there's biases that they're experiencing, to make sure that that's adequately captured. So I hope I'm like a year away of publishing it, so hopefully it'll come out soon. But I think that, again, that alignment is really important, and making sure, again, it's adapted and adjusted to the population that you're most interested in understanding the experiences from.
Wonderful. Well, we'll definitely look forward to that when it comes out. And I think we are just about at time, and I'm not seeing any additional questions. So
I answered all the questions. That's so great. But definitely feel free to email me if there's anything else.
Absolutely. And again, a huge thank you to all of our speakers on this stigma panel. Some really great presentations and discussions. And with that, I'm going to turn it over to my colleague, Dr. Clay Mash, who will be moderating our next panel. Thank you.
Great. Thank you, Dara. And thanks to the preceding speakers. I'm Clay Mash. I'm a program officer in the NIH Environmental Influences on Child Health Outcomes program. And this session of the Research Festival will highlight research on determinants. Our first speaker is Kelly Endries, who's a research associate at the Johns Hopkins Bloomberg School of Public Health. And she will speak on behavioral determinants of arsenic-safe water use among Great Plains Indian Nation private well users. Results from the community-led Strong Heart Water Start arsenic mitigation program. Kelly, I'll turn it over to you. Oh, I think
there we go. That's better.
Yeah, okay.
Great. Thank you so much, Clay. Let me just share my slides so that we can get started. Okay. You should be seeing.
Yeah, that looks great. Yes.
Okay, perfect. Well, I'll go get ahead and get started. Hi, everyone. Thank you so much for being here today. And thank you, of course, to the NIH Office of Behavioral and Social Sciences Research for recognizing our work and inviting me to speak. As Clay said, my name is Kelly Endries. I'm a faculty member at the Johns Hopkins Bloomberg School of Public Health. And today I'm going to be talking about the behavioral determinants of arsenic-safe water use among Great Plains Indian Nation private well users. These are findings from a randomized control trial we did, the Strong Heart Water Study, which is a community-led arsenic mitigation program. So first, really to cover some of the background of why we were interested in this study. So you may not know, most people, or you probably know, most people in the United States receive water from their municipal water supply, which is regulated and managed following guidelines set by the EPA. And of course, while we all know there are some challenges with this system, over 2.1 million individuals still use private wells for water. And for these individuals, the burden of water testing and water treatment is actually left to the individual private well user. And the map I'm displaying here shows the US Geological Survey estimates of arsenic concentrations in groundwater supplies across the United States. So as you might expect, rural communities, which generally have limited access to public water supplies, represent the majority of the population using private wells. And American Indian communities, especially those in the Great Plains and Southwest, so kind of these areas on the slide, where groundwater arsenic contamination is common, are also disproportionately impacted due to their reliance on private wells and the fact that these are often rural communities. So I'm sure we're all aware of the health impacts of acute arsenic exposure, but there's a lot of health impacts from prolonged low-level elevated exposure. So these include things like skin, lung, and bladder cancers, cardiovascular disease, diabetes, kidney disease, as well as developmental and cognitive impacts if exposed in utero or early childhood. So it's really important to look at arsenic contamination in water. So based on these factors, we decided to implement the Strong Heart Water Study, nested within this larger Strong Heart study that's been conducted for many years together with American Indian communities in the Great Plains region. And the goal of our study was really to develop and evaluate some community-led interventions to reduce arsenic exposure among private well users in these communities. So you can see in this cutout of the Great Plains map on the slide is really where we were working. And in some of our communities, actually up to 1/4 of private wells are estimated to have elevated arsenic. So this is a really important issue that these communities wanted to investigate. So when we were developing the study, the Strong Heart Water Study, we conducted pretty extensive formative research to inform and design what we really wanted to be a community-based arsenic mitigation intervention that not only addressed community concerns and needs, but was delivered in a method that the community considered appropriate. So we did both semi-structured interviews and focus groups, and then we also conducted a pilot study of our arsenic filter. So for our actual filter device that we decided to use, we went with a multi-pure point of use absorptive media filter tested to remove, which was to remove the arsenic. We really chose this filter for a variety of reasons, but especially due to cost and maintenance concerns in our study area. So it was installed in the household by the Tribal Housing Authority with funding from the Indian Health Service. And you can see in the diagram here that I'm showing is it was installed underneath the kitchen sink and ran to a second filter faucet that was installed alongside the main faucet. And so we went with this method because we wanted to reduce the burden of water use on the filter. So the filter faucet would be used for things like drinking and cooking, and the main faucet and other faucets in the household could be used for other water uses. So as we all know, behavior change is really difficult when you're implementing an intervention like this. So to promote the use of the arsenic removal device and the filter faucet, we developed a program that included mobile messages, testimonial visits, and home visits that promoted drinking and cooking with water from the arsenic filter faucet. And then these home visits and testimonial visits also discussed how to change the arsenic filter, which of course was, we went over this with all of the participants when the filter was installed. All of our content and intervention was delivered by an American Indian-owned local partner organization, Missouri Breaks Industries Research, who were instrumental both in the development and ran all of the implementation for our project. So when we were developing our different interventions, we used our formative research, and then we were also informed by models of behavior change. So while we incorporated a few different models, we primarily used the risks, attitudes, norms, ability, and self-regulation model of behavior change, or the RONUS model. This is really an easily applied method to measure behavioral factors and then take that and assess their influence on behavior, design tailored strategies to change those behaviors, and then ultimately measure the effectiveness of the strategies on the behavior change. I'm just showing a simplified version of the RONUS model here. So you can kind of see that in the middle, we have all of these different types of factors, and then there's specific behavior change techniques that are designed to target each type of factor, which then results, hopefully, in your desired behavior change. And all of this is influenced by the social, physical, and personal context that you're working in. And so we use the word behavioral determinants or behavioral factors or factors kind of interchangeably, but this is any factor which strongly influences and affects behavior as it relates to health. So I want to highlight how our behavioral promotion targeted these specific risk factors to understand the different messaging that we provided. So one factor that, or behavioral determinant we were looking at, was perceived vulnerability, which is a risk factor defined as the perceived risk of health problems from arsenic exposure. In our mobile messages, we were really targeting this by emphasizing the health risks associated with arsenic exposure. And then this was further emphasized in home videos, or in the home visits and videos with video testimonials about health risks of arsenic exposure. And then for self-efficacy, another factor that we looked at, this is an ability factor defined as the belief in one's abilities to confront and manage possible situations. In our mobile messages, we looked at, we emphasized different strategies to overcome challenges that we anticipated with the filter, and different suggestions to facilitate filter use or use of arsenic safe water. And then in our home visits and in the videos, we went more in depth into troubleshooting arsenic filter use. So to test our intervention, we developed a randomized control trial. We enrolled households with elevated water arsenic levels in their private well, and we had two different study arms. So first we had our mHealth and filter arm, which received the arsenic filter installation, as well as mobile reminders, those mobile messages promoting use of the arsenic filter. And then the intensive arm received the arsenic filter installation and mobile messages alongside home visits and the promotional videos that I discussed on the last slide, promoting use of the arsenic filter and how to change the arsenic filter. We enrolled households between July 2018 and November 2019, and our follow-ups occurred about 2 years later from November 2020 to November 2021. So in our questionnaire that we delivered at our baseline and follow-up visits, we were assessing 11 different behavioral determinants asked through 37 different item questions. So for example, 2 questions based on the behavioral determinants I already introduced. For perceived vulnerability, we were looking at one example question was, how high or low are the chances of you getting health problems from arsenic if it's in your well water? And then we also looked at self-efficacy through questions like, how sure are you that you can get arsenic, that you can use your arsenic filter faucet every time you need water for drinking in your home? So when we were asking these questions, we were assessing them using a 5-point Likert scale, which you may be familiar with. So for that perceived vulnerability question, it goes from 1 very low to 5 very high. So you could say, my response is a 5. I think it's very high, very likely that I could get health problems from arsenic in my well water. But the scale would also be things like 1 strongly disagree to 5 strongly agree, or like 0% sure to 100% sure, depending on the question that's asked. So when assessing the behavioral determinants, our main outcome was the exclusive use of arsenic-safe water. This was self-reported, and we assessed at baseline and our follow-up visits as well in our questionnaires. And we were really defining exclusive use of arsenic-safe water as use of the filter faucet water, use of bottled water, which happens sometimes in our study setting, and then also water from the municipal system. We had 3 different outcomes, exclusive use of arsenic-safe water for drinking, for cooking, and then for a combined drinking and cooking variable. So our first finding that we really wanted to look at was the change in our behavioral determinants assessed with that Likert scale over our 2-year study period. So overall in our study population, we found that all of our changes actually, regardless of significance, were in the hypothesized direction. So we weren't seeing anything really unusual. And I'm just highlighting some of our main significant findings here. So first, we saw an increase in the perceived vulnerability to health problems from arsenic exposure. We also saw an increase in the perceived ability to obtain safe water for cooking, so this self-efficacy variable. We saw a decrease in the perceived use of arsenic unsafe well water for drinking and cooking in the community. So this is a descriptive norm or a perception about behaviors commonly performed by others in your community. And then we also saw an increase in perceived disapproval of peers using arsenic unsafe water for drinking and cooking. And this is an injunctive norm. So this is talking about perceptions about behaviors that you perform that others in your community commonly approve or disapprove of. And I will say we did combine our study arms here for this analysis because we didn't see any difference in behavioral determinants at baseline between the 2 groups. And because of the COVID-19 pandemic, we had a little bit lower enrollment than we wanted. So this helped increase our sample size when we were looking at these variables. So the next finding that we were looking at was, of course, we want to know how did the behavioral determinants influence arsenic safe water use? So we looked at the baseline factors associated with arsenic safe water use for both drinking and cooking at follow-up. We found that higher perceived vulnerability, higher commitment strength, and then higher self-efficacy were all associated with exclusive use of arsenic safe water for both drinking and cooking at follow-up. And then specifically for self-efficacy, that was 3 different factors. So confidence in one's ability to find local resources to learn about arsenic and water. It was also confidence in the usefulness of local resources to resolve an arsenic-related problem, and then confidence in the ability to use the arsenic filter for drinking in the home. So people who had high confidence in these abilities were more likely to use the arsenic-safe water. And then lastly, we also really wanted to look at the influence of behavioral determinants on changing the arsenic filter cartridge. So this was really important because filter change was recommended after 1 year of use, and all households were provided a replacement filter. So we found that higher perceived chance of health problems from arsenic in well water and a higher confidence in obtaining drinking and cooking water with a safe level of arsenic at baseline were both associated with changing the arsenic filter cartridge over the study period. All right, which brings me to the summary of our findings. So that was a lot and really specific, but just to highlight some of the things that we talked about. So really importantly, we found that perceived vulnerability and self-efficacy both influenced exclusive use of arsenic-safe water and were changed by the Strong Heart Water Study program. So the program was able to influence factors that also proved influential on targeting or on our targeted behavior. In addition, perceived vulnerability also influenced arsenic filter cartridge change. So we saw that perceived vulnerability to arsenic and water, the health impacts of arsenic, was really influential in different aspects of our findings. And then these all, of course, give us insight into behavioral determinants that we should target in future interventions. And ultimately, our results really show that through this kind of thoughtful and theory-driven formative research that informs the intervention development, you can impact behavior change interventions, at least for arsenic exposure. And finally, we see that this is a model that can serve kind of as a design of theory-driven intervention approaches to engage communities to reduce arsenic exposure. All right, so of course, there's many people I need to thank super quickly. You can see it on the slide. I know I'm a bit over time. So thank you so much, and I'm happy to take any questions. Oh,
Thank you so much, Kelly. That was a fantastic talk. Very interesting findings. And we do have time for a question or two if you want to put it in the Q&A. One question, Kelly, is that since when you're working with a tribal nation, you're talking about potential cultural differences, of course. And so I'm wondering how you prepared. You mentioned some meetings in the community when you were planning the work, but I wonder if you could speak a little bit more about how you prepared to communicate the most effectively with the tribal members about planning the intervention arm.
Yeah, so that was definitely something that we considered a lot. And thankfully, I think having our local partners, so Missouri Brakes Industries Research Institute, MBRI, who we worked with, had already done a lot of work, especially with our partners at Columbia on different studies. And so having them being the ones who were running the whole program there, they were running all of our formative research, and then when we were implementing the intervention, running all of that, having them be the ones who communicate with the local community really helped, because it's people who are part of the community, go through the same issues, and really understand that was a big benefit to our study, and without that would have been very difficult to implement. So I think that was the most important part of that, but certainly something we needed to consider.
Yeah, great. And did you share with the participants their results in a way that could be, so that they knew kind of how they compared in their decision making to other members of their community?
Yes, yeah. So that's something, well, I mean, not only did we want to do that, but coming in to work with the tribes, that's something that they require as well. And everyone's very clear that that's going to happen. So we communicated the arsenic well water results every time those were tested. So at every visit, we were testing the well water for arsenic and communicating those results. And we did that even if people didn't end up enrolling in the study. And then we're also continuing to communicate our findings. So we're just finishing up, kind of writing our manuscripts and publishing everything, and continuing to work with our community to disseminate those results.
Great. Well, thank you again, Kelly. Really appreciate it.
Great. Thank you so much.
Next, we have Dr. Lauren Schmitz, Assistant Professor of Public Affairs at the University of Wisconsin-Madison, and she'll be speaking on in utero exposure to the Great Depression is reflected in late life epigenetic aging signatures. Dr. Schmitz.
Thanks so much, Clay. Let me see if I can get this queued up here. All right, are you all able to see the presentation mode?
Yes, there we go. Looks great. Thank you.
Great. Well, thank you so much for having me here today. It's a real honor to be asked to present my work, and a huge thanks to BSSR for organizing this festival. In way of training, I'm an applied health economist with additional training in human genetics. And so my research really uses both social and biological data to understand how social inequality across the life course affects disparities in aging. So this particular publication was a joint work with Valentina Duque, who's at the School of Public Affairs. So in terms of motivation for this work, we know from a lot of research in population health and in the social sciences that in utero and early life events can affect adult outcomes, including health, education, and wages. However, overall, there's been much less focused on aging, so much less research that's connected kind of in utero, really, really early life experiences with aging later in life. That's starting to change, but that was certainly the case when we first started this work. We also know that economic fluctuations occur frequently and affect population well-being. So we know that recessions and depressions can really affect population health. So that was another reason for looking at this particular exposure. And in terms of the biological literature, in terms of why we should care about the in utero period, we know that this is a really sensitive or particularly critical period for human development. And in terms of the biology, one reason this is the case is that this is when epigenetic mechanisms in our body are really refining genetic programs to be optimally responsive to present and future environmental challenges. So they're really calibrating themselves based on kind of the feedback that they're getting from their environment. So the feedback they're getting from maternal exposures, maybe stress, lack of nutrition, things of that nature can change how a fetus is developing and responding to their environment. So this particular period in the life course is thought to be a very sensitive or critical period for human development. But I would say as a whole, causal research on the long-term impacts of fetal epigenetic programming in humans is really rare. So this kind of calibrating of epigenetic mechanisms based on the environment, this is called epigenetic programming. And as far as what we know in humans, the research is quite sparse. The few exceptions are really limited to a handful of natural experiments. So you may have heard of the Dutch Hunger Winter Family Study. Project Ice Storm is another example, and some research from Holocaust survivors. But the vast majority of what we know about these mechanisms is in animal models. So what we do in this study is we asked, how do epigenetic aging outcomes vary with exposure to economic conditions in early life? And I'll talk about in just a little bit what I mean by epigenetic aging outcomes, but we're going to be linking these early life economic exposures with late life biological aging outcomes. And we're going to first examine the causal effect of exposure to the Great Depression in early life on late life accelerated epigenetic aging using variation in economic conditions across states and years during the Great Depression. And then second, we're going to identify when in childhood these effects had their greatest impact. So we're not going to just assume that the prenatal period was the most sensitive. We'll look across all periods from the prenatal period through age 16 to see when the effects of the depression appear to be strongest in terms of their impacts on later life aging. So why focus on the Great Depression? Maybe this is obvious, but I think it's worth mentioning. This was a really massive economic shock. A quarter of the US labor force was unemployed, fortunes were destroyed, and there was no social safety net at the time. So this was really a huge unexpected financial and psychological shock for many households. There were also no prenatal vitamins and things like that, or other nutritional supplements or ways to gain access to those for women who were pregnant. There was also really dramatic geographic and temporal variation in economic conditions during the Depression across states. And this is really important for kind of this particular quasi-experiment that we're going to be looking at, because we're going to be exploiting that variation to try to get at a causal effect. And the third is for those of us who do research in aging. We can use the Health and Retirement Study. So the Health and Retirement Study is an NIH-funded study on aging. It's the largest in the world. It's been going on since 1992. And of interest for this particular study is that it was also the first nationally representative study in the United States to collect epigenetic data that has the sample size and the geographic variation that we needed to really exploit this quasi-random design of looking at how kind of where you were born might affect your later life health. And so I think this also really expands possibilities for future causal work in epigenetics. So in terms of our exposure of interest, in terms of how we capture the Great Depression, we're going to be looking at a wage index by state. So this is capturing both farm and non-farm wages across states. And it's indexed to the year 1929, before the shock, the crisis. So you can see, 1929 is at 100, and then we see this really steep decline in wages across states, and then a slow rise after kind of the low point of the Great Depression in the beginning into the New Deal. And each of these lines is a different state. So you can see that, while there is this overall downward and then upward trend, the depth of that trend really varies across states. So this is again, the variation that we're going to be exploiting in our analysis. In terms of the HRS sample, we're going to be looking at respondents who were born between 1929 and 1940 who had their blood drawn in 2016. So these individuals were quite old when they had their blood drawn to have their epigenetics profiled. They were between the ages of 75 and 84 at the time. And we had about 832 individuals that we could use from the data for this. Obviously, a big elephant in the room here is mortality selection, and we'll be discussing that a little bit in a few slides. And so then we link state level data on wages to individual state of birth from the in utero period through age 16. So for each of these individuals that were profiled in the HRS, we know the state that they were born in during the Depression. And so we're able to link these state level data, historical data on wages to individual state of birth across their childhood. And then in terms of our outcomes, we're going to use 6 publicly available epigenetic aging measures that were constructed by the HRS. So let me just talk a little bit more about those because many of you may not have heard of them. So this is the outcome that we are going to be focusing on. These have kind of taken the geroscience world by storm. They're the most robust and accurate biomarkers of biological aging to date. So, a big issue in the aging literature has been how do we identify whether people are aging faster or slower than their chronological age. We all know chronological age is an imperfect measure of aging because we all don't age at this nice linear rate. Some of us age faster and some of us age slower. So if we have a more accurate biomarker of that accelerated or decelerated biological aging, we can start to look at what factors impact that. So these clocks in particular have been a really great measure of biological aging. And I don't have too much time to talk about kind of how they're composed, but basically we're looking at DNA methylation, which is a specific type of epigenetic modification. And how these are created is that they're regressing chronological age or some sort of phenotypic measure of aging on a set of these CPG sites, which are areas in the genome where we see DNA methylation. And they're using supervised machine learning methods to kind of find, what sites on the genome are most highly associated with epigenetic aging or with age. I should say with age or with biological aging measures. So they're using machine learning algorithms basically to construct a biomarker of biological aging that is built by looking at different levels of DNA methylation across the genome. And then the outcome of interest for us, what we're going to be looking at is deviation between epigenetic age and chronological age. So these algorithms will spit out somebody's biological age. So, maybe your biological age is 35, but chronologically you're 38. And so then we would be using that deviation to look at whether you're aging faster or slower than your chronological age. Really quickly, there's been over 30 epigenetic aging measures developed to date for adults. These are all constructed using different training phenotypes, different training samples, and across different tissue types. We're going to be looking at some of the more popular ones. And in particular, these second and third generation measures train the DNA methylation on actual clinical markers or even on mortality risk. So they've been found to be a lot more sensitive indicators of biological aging than some of the earlier clocks that were just trained on chronological age. This is our basic empirical specification. So we're looking again at epigenetic age acceleration for an individual who is born in a given state and year. Then we're regressing that on, again, these aggregate wage indices from the preconception period all the way through age 16. And then we control for sex, race, maternal education, and then a lot of other important demographic and economic controls at the state level to better isolate the effect of changes in wages from other factors that were going on at the time. So here are our first round of results. Here we're just looking at the in utero period specifically. So we wanted to see how wage declines in utero are affecting accelerated epigenetic aging later in life. Everything you see here is standardized, so you can compare across effect sizes. These are different epigenetic aging clocks that we're looking at, and you see that we find significant results for these second and third generation measures that are kind of, thought to be a little bit more sensitive indicators. And here we see, for example, that a 1 standard deviation decline in wages during the Great Depression, which is about just half of the overall declines in wages that were experienced during this time, is equal to about a 0.38 or 0.4 standard deviation increase in accelerated aging later in life. This translates to about 1.7 years relative to chronological age. So we're seeing that people are aging, roughly 2 years faster than their chronological age later in life if they were exposed to more severe conditions during the Great Depression. In this next model, we then looked at the entire childhood period. So we have the preconception period, which here, we don't see any effects. And then we also have wage exposures from the in utero period all the way up through age 16. So this is an incredibly stringent model. These coefficients are all in the same model. So these aren't from different models. And again, you see here that really the only period that seems to matter is that in utero period. We looked at mortality selection. I don't have too much time to go into this, but basically what we find here is that our results are attenuated by about 9 to 38% due to mortality selection, which is what we suspected. The individuals from these cohorts that survived to have their blood drawn are likely the healthiest of individuals who were born during that time. And so basically what we see here is that if anything, our results are biased downward because of mortality selection. We also wanted to look at results with other aging outcomes. How do these epigenetic aging measures compare with other aging outcomes that we typically use in the literature? And here you see that in general, the other aging or health measures are less precise and lower in magnitude than these two epigenetic aging outcomes, both Grimmage and Dunedin-POAM. So especially in such a small sample, we only have 832 people in this sample. We were really much better poised to see more precise results with these epigenetic aging measures. So again, they appear to be more sensitive indicators. We also found that these epigenetic aging measures predicted mortality in the next wave. So people's blood was drawn in 2016. And then we looked at the probability of death in 2018. About 7% of our sample passed away between 2016 and 2018. And here you can indeed see, again, these are all standardized, so you can compare effect sizes. We see individuals with higher Grimmage or Dunedin-POAM, more accelerated epigenetic biological aging, more likely to die in the next wave. We still see a really strong effects for self-reported health status, which is, still this great indicator of mortality. However, if you recall from this slide, it doesn't seem to be picking up on any of these in utero exposures. So overall, the epigenetic aging outcomes appear to better pick up on both early life conditions and in terms of their prediction of later life mortality. We did a bunch of additional analyses and robustness checks, which you can take a look at in the paper. We looked at other measures of economic conditions, and then we also looked at whether results were being driven by other co-occurring events, including the Dust Bowl and New Deal relief spending, and we just didn't find very much there. So just to quickly wrap up, we find that adverse economic conditions during the Great Depression resulted in accelerated biological aging later in life. A one standard deviation decrease in wages resulted in about a 1.7-year increase in epigenetic age relative to chronological age later in life. The effects of the shock appear to be localized to the in utero period specifically. And we think that these results are likely a lower bound of the true effects due to mortality selection. And finally, epigenetic aging measures appear to be more sensitive indicators of disparities in aging that are connected to fetal programming and to subsequent mortality. So if you're interested in taking a look at the paper, it was published in PNAS last year. So we have lots of additional analyses in there. I also wanted to take a quick plug for my lab, which I'm just getting started here at the University of Wisconsin, the Biosocial Equity Lab. We'll be launching a website soon. So if you know of any interested graduate students or undergraduate students, send them my way. And huge thank you for funding from the NIA for this work, and also for the center from the Center for Retirement Research. So thank you.
Thank you so much, Dr. Schmitz. It's really, really remarkable findings. We have a couple of minutes for questions. Using the Q&A, there's one question also in the chat, which is whether you use brain aging estimation to account for epigenetic effects on aging.
Brain estimation aging. I'm not sure if I know what they're referring to.
Yeah, I'm not sure.
I'm not sure. Sorry about that. I'm not sure. In general, was that your question, Luana?
Yes. It's a new trend in neuroscience. Do not focus on merely date of birth, rather the age of the brain. So again, machine learning allows us to see how old is a brain as compared to the actual age. And I thought that can be a wonderful, intersection of your job.
Thank you. Yeah, I'll have to keep my eyes peeled for those. There's just so many incredible findings coming out in this field right now. So it's really hard to stay on top of, honestly.
So you are on top.
Thank you. Thank you so much for your question.
Okay, we're about at time. Thank you again, Dr. Schmitz, for a wonderful talk.
Thank you.
And our third talk in this session, Dr. Luana Kuloka, who is the Empower Distinguished Professor at the University of Maryland at Baltimore. And she'll be speaking on behavioral and biological predictors of placebo effects. Dr. Kuloka?
Yes, I would love to thank all of you. This has been a wonderful day. Thank you to OBSSR. It's my first time, and thank you to the person who nominated us and our lab. So the goal is to tell you a little bit about a paper that was selected, but I would like to contextualize what we do. So we study placebo effects in the context of chronic pain, and also we want to understand how we can control for placebo effects and disentangle placebo versus treatment responses. So we know that especially for pain, every time we experience pain, we feel pain with our emotions, with our perception, and in technical words, we describe that as affective and somatosensorial experience of pain. So every time we give a drug that can be an opioid or a surgical procedure or integrative medicine, always the treatment is given within a context that we call psychosocial context. This can augment the outcome. And this is an example. If we provide the same identical dose of pain therapeutics, we can observe a different outcome when we use a PCR versus a classical IV injection with health provider informing now you are receiving the treatment. And so we have two classes, opioid-based versus non-opioids. You can see that every time the patient are aware of being treated, the reduction of pain is much larger. Literally, we can enrich, augmented the outcome by using this psychosocial context around any treatment. And in this case, we study placebo without any placebo. There's a difference between hidden versus open administration of painkillers represent the placebo component or psychosocial component. So in our lab, we have been interested in understand the predictors of placebo effects. So focusing on genetic, on socio-demographic and psychological predictors. And we also understand that this phenomenon is a neurobiological phenomenon because different parts of the brain circuits can contribute to the perception of nociception, placebo effects, but also negative placebo effects that we call nocebo effects. Our lab wanted a couple of years ago to explore this argument, mostly in the area of chronic pain disorders, because so far the majority of research has been conducted in health controls. So our very simple questions was, do people who experience chronic pain since years experience placebo effects similar to health controls when we use the same paradigm? The paradigm in this case is an in-person screening visit to characterize the phenotypes of temporomandibular pain disorders. Then we do a quantitative sensory test to measure individual sensitivity to heat thermal stimulation. And then we measure expectations before a conditioning where participants receive pain, no pain several times. And to test for placebo effects, we tell them that these electrodes, that in reality is sham, can reduce the intensity of the thermals. In reality, we reduce all the pain at the same identical level during the testing phase. So the first question was, do health controls and temporomandibular pain disorder experience similar distribution of placebo effects? So we plot here the delta between the two set of trials, control and testing trials, identical pain stimulation, and you can see that the distribution is fairly identical. So both chronic pain patient and health controls experience placebo effects that vary from no at all or nocebo here versus larger effects. We quantify that in terms of percentage. In chronic pain patient, 53.4% of our participants respond to this manipulation, and 67 controls respond as well. So largely smaller for chronic pain patient, yet huge, more than 50%. And I invite you to think about clinical trials for pain therapeutics to understand how this can somehow jeopardize the success of many clinical trials. Also, we want to see in terms of number needed to treat, that is an index to validate a new or a current pain therapeutic, how does the placebo somehow is compared to some other treatment that we use, like anticonvulsant for neuropathic pain, opioids for musculoskeletal pain. And you can see that TMD had NT between 1.5 and 2, so it's relatively large, again suggesting that the placebo phenomenon can be meaningful, or at least a nuisance for clinical trials that we need to know how to handle. And this is the paper that has been selected for this festival. We were interested in understand which are the predictors, and in the literature there were many studies indicating that somehow different psychological traits or factors can predict placebo In some lab was optimism, in some other neuroticism, in some other positive and negative effect. So what we did, we use a more comprehensive and again computational approach to understand which are the psychological predictors of placebo effects. This is our population, again, TMD, health controls, and we split in responders and non-responders, as you can see, and we test placebo effects 60 times. And in red are the placebo non-responders, also called nocebo responders. What we did, so we use the NMH RDOC framework and principal component analysis, where you can see our 33 surveys being used, but mostly were published in the literature, and we use this framework to talk about valence. So our valence is based on this computational modeling that came up from our 33 surveys, where emotional distress, reward seeking, pain-related fear and catastrophizing, empathy and openness. These are well-established valences where we know that distress and emotions can influence pain in particular, and our goal was also to understand how this kind of valences can influence also placebo effects and expectations. And so I will show to you, it's complex, but we will look at this together. We look at expectations, conditioning, because we use our conditioning to manipulate patient expectations, participant expectations, and study placebo effects in a laboratory setting. And eventually placebo effects characterized as magnitude, extinction, and responsiveness. So let's start with our two cohorts, chronic pain patient versus self-controls. You can see that we see a group difference for the reward-seeking component. And indeed, this is not surprising. Patients who suffer from pain have a different anticipation of rewards. They wish to feel better. When we provide nociceptive, painful stimulation to people who don't know what chronic pain is, the reward is not there from the anticipation of being treated. Fear and catastrophizing is always associated with lower expectation. The more our patient catastrophizing, the less they expect to benefit. And empathy and openness, on the contrary, is associated with larger placebo effects. This kind of patient that no matter what they experience, they continue to maintain this sort of resilience, positive mindset. In terms of ability to learn and to modulate pain, conditioning and acquisition rate were our indexes. And you can see that the more they are distressed, the worse the ability to learn and to retain what they learn. When we talk about placebo effects, it become also very fascinating to me. In fact, placebo effects, there are no group differences in both people who are pain-free and those who suffer from chronic pain. Emotional distress is associated with a smaller magnitude of placebo effects, larger rate of extinction, and lower probability to respond to a placebo. Fear and catastrophizing is again associated with lower placebo effects, as we saw also for expectation, and lower likelihood to respond to placebo. So this paper has been published in Pain Journal, and I hope all of you can have access. We continue this story with another paper published, and I thought that is in line with this meeting today, where we look at the race concordance. We work in Baltimore. It's a very diverse and ecological environment to study disparities, racial biases. And so we start to keep a record of the race, ethnicity of our patient, as well as our participant in the lab who ran this experiment. So you can see that every time we had race concordance, same race between experimenter and study participant, we have larger placebo effects as compared to different race. We are still working on that, but I wanted to somehow share this with this audience. And another thing that is relevant is the sex, when we talk about predictors. So women have, at least in this cohort, larger placebo effects. And we dive into the results and we measured the gonadal hormones for women. We kept record of their mens. And you can see that for pain threshold in the mid-follicular phase versus luteal phase, our women participants tolerate different intensity of pain. So they become more sensitive during the luteal phase. And that again has been more established, and they are different, as you can see, from both mid-luteal phase and men. But interesting, and probably we were the first to say something about that, expectation also varies. You can see that the expectation change in women based on the mid-follicular versus luteal phase. In mid-follicular phase, women have larger expectation than men, as well as larger expectation than the phase where we have the luteal periods. Also, when we look at concordance again, when we have same participant experimental sex, the placebo effects in women tend to be smaller, but we didn't observe this effect in our patient, neither in health controls. This is only true for chronic pain participants. And finally, we also are interested in genetic variations. So we look again at the 3 SNPs published on placebo analgesia and pain that are the COMT, the gene for endogenous dopamine, the FA, endogenous cannabinoids, and OPRM1, endogenous opioids. So if we do a little of math for all the variants, we have 12 possible combinations. So for example, a person in the audience can be G, MET, MET, PRO, PRO. And so you can see that based on the carriers that they are characterized by, they can have a different magnitude of placebo effects over time. We test for 18 times. And so those in transparency are those who didn't show any placebo effects. So the phenomenon is complex, but we are in a position to understand more and hopefully translate this research from bench to bedsides. One day we hope that by understanding A, B, C, D, and so on from patient or participant characteristic, we can design robust modeling to understand if a chronic pain participant may benefit from placebo manipulation or not, and compare that with the response to active treatment. So in general, to conclude, we hope that this research will continue because it can be very promising not only for methodology of clinical trials, but also for pain management. And so for those who are interested in investigating the placebo phenomenon, it is very important to design the study well, with the right control, including the no intervention arm, but also conducting larger studies so that we can use this computational machine learning approach to better phenotype predictors of placebo effects. In future direction can be omics and more animal research that is quite missing in the fields. And with that, I hope to thank all my lab, but in particular those who organized this meeting. And the last thing that I would like to say is that next week we launch this book that is an open access Oxford University Press book that everyone can read for free. So I'm happy to share the link, or follow me on Twitter and you will find this resource for free with a lot of information about placebo. And thank you very much.
Thank you so much, Dr. Koloka. That was a fascinating talk. So now we have a few minutes for questions in the Q&A. One question, one thing that you kind of hinted at the end, and this is, this is a large speculative overarching question, but I'm wondering what kinds of ways you think that understanding placebo effects better might actually be put to use in painful treatments in medical settings?
Yes, thank you for the question, Lei. Definitely, learning more about placebo can help design clinical trials, and having predictors allow us to do modeling to understand whether a treatment is efficacious or effective in a subgroup of patients or not. In terms of, psychologists, healthcare providers can be helpful to know how to harness this phenomenon, because truly we can improve the response to active treatment, not just placebo. So by being able to handle this phenomenon, we can reduce symptom distress, suffering, and so on. And finally, for any, pain researcher can be helpful to add the pain modulation as a sub-aim or a topic to investigate, because still the descending pain modulator system, that is one of the most beautiful parts of our brain, remain underexplored.
Thank you. Another question, how might previous pain history and lived experience or medication treatment history and lived experience of individuals impact the results you found and or people's placebo experience and ratings in general?
Interesting questions. We observe that those people who tend to be exposed to a larger amount of pharmacological treatment tend to respond less to placebo. So somehow the use of exogenous opioids and other pain therapeutics interfere with the ability to activate this sort of inner healing that our body is able to put in action. The prior experience is not only limited to pharmacological approach, but also trauma. In the lab now, we see that those people who have been exposed to prior negative experience from, unsuccessful therapeutic experience or early life adversity, impact the ability again to display some placebo responses.
Great, thank you.
Thank you.
Another question, do you measure individual differences in things like, aspects of sensory acuity, like individual pain thresholds? Is that something you have to assess when you're mapping these out?
We tend to use both assessment of visual acuity, but also sensorial acuity. We use the thermal stimulation, and one of the approaches to see if whether different pain sensitivity can influence placebo effects, but actually is minimal. And the same for vision. I mean, we don't have enough spectrum. We don't study people with hypoacuity for vision, so I can't answer this question, but definitely we see an amplification of the effects by using virtual reality, where somehow we can capture and amplify the experience of the cues we use through, for example, immersive reality.
Oh, interesting.
Yeah.
Okay. Well, we're at time now. Thank you so much, Dr. Koloko.
Thank you.
And this is the end of the session. We're at a break now. I want to thank our other speakers as well. And we will move on to break now and then return in 10 minutes, I believe.
So good afternoon, everyone. It is now 2:50. I am Melissa Green Parker, and it's really a pleasure to join you this afternoon as the moderator for session 4, which has a focus on youth. I'm here representing the NIH Office of Disease Prevention. And so after providing some brief introductions, I will turn the microphone over to our speakers, who will deliver 15-minute presentations and subsequently address your questions in the Q&A box. So first, we will hear from Drs. Tamar Rubenstein and Jennifer Wu. Dr. Rubenstein is an assistant professor at the Albert Einstein College of Medicine, and Dr. Wu is a postdoctoral fellow at the National Institute of Environmental Health Sciences. So welcome to you both.
Thanks so much for having us. It's really an honor to be here today and to be able to discuss this paper that our group recently published on the health equity implications of missing data among youth with childhood onset systemic lupus from an international registry. So I'm joined here today with our first author, Jen Wu, and both of us will be tag teaming this presentation today to give you a little bit of the story about how this project came to be, how we're using it as a springboard for further research, and how it's influenced the design of a study that attempts to address some important health inequities in childhood onset lupus. So first, I'd like to give you a little bit of background on childhood onset systemic lupus, or CSLE, for those who aren't familiar. Lupus is really the quintessential systemic autoimmune disease. In adults and in children, it can affect pretty much any organ, and it's famous for its breadth of manifestations, many of which may severely impact quality of life. 20% of people with lupus will develop their disease in childhood before or at 18. And when this occurs, the disease is unfortunately often worse in severity, with more prevalent major organ disease, in particular renal disease and brain disease. But moreover, lupus is really a dramatic disease example of health inequity. It affects several marginalized race and ethnicities at much higher prevalence rates. And this is potentially related really to biological embedding of trauma and probably longstanding differential environmental factors associated with systemic racism. And across almost every poor outcome that we've studied related to lupus, including end-stage renal disease and mental health outcomes, there are large disparities, specifically disadvantaging Black and Hispanic youth. But especially devastating are the differences that have persisted over time in mortality rates, and especially in Black and Hispanic teens and young women. So in Black and Hispanic teens and young women, lupus is the 5th leading cause of death, and Black children with lupus are twice as likely to die as their white counterparts.
Oh, sorry, you're not sharing your screen.
Right. Yeah.
Oh my gosh. Sorry, thank you for letting me know. Hold on. Okay. Can you see my screen now?
Yeah, looks good.
Okay, I'm so sorry, everyone. I guess it's towards the end of the day. We have to have one snafu, right? All right, so, okay. So, so to address the disparities that we see in childhood onset lupus, our groups and others have planned to look at potential mediators of poor outcomes in childhood onset lupus, with the goal of finding targets that we can affect to mitigate lupus damage and mortality. And like I mentioned, one of the most troubling things we've seen in lupus epidemiologic research over the past several decades is that despite overall improvements in morbidity and mortality related to improved treatment, the gap between socio-demographic, especially racial groups, has not improved over time. And to improve health equity, we not only need to ensure that we're including the highest risk patients in our research so that we develop knowledge about what interventions improve their outcomes, we need to consider how we develop interventions that differentially improve their outcomes so we can decrease those persistent gaps and health disparities. And if we do research that does not adequately include these populations, we really run the risk of not only not achieving health equity, but actually worsening health disparities. So one of the major areas that may be addressed in improving health equity is around health behaviors associated with engagement and care. And the most obvious but really critical area to tackle first with regards to engagement and care is routine visit follow-up. Though there are certainly other areas of engagement and care that could be considered, like self-care and self-management. Our group specifically became interested in disengagement and care because it's likely very entangled and influenced by social determinants of health, social needs, and it may be impacted by symptoms of depression, which has been an ongoing area of research interest for our team. Depression is really highly prevalent in youth with lupus, and importantly has been related to marked health disparities across racial groups. So our hope is that interventions that target engagement may differentially help improve outcomes in vulnerable youth. So one of the first places we looked to investigate this question was the CSLE Registry of CARA, the Childhood Arthritis and Rheumatology Research Alliance, which had collected data on over 1,000 youth with lupus and over more than 70 sites in North America, and is really built to power studies in youth with lupus. While the registry was actually initially designed for comparative effectiveness studies, it also enables large observational studies that really can look at important disease outcomes. But like most real-world registries, there's a systemic problem of missing data. And with respect to that, our initial question started off as whether the registry was going to adequately represent the highest risk youth and complete data from them. And this quickly led to a larger question about how we could ensure that the research coming out of the registry in general would improve health equity and not worsen health disparities. So to help answer this question, I turned to Jen Wu, who's one of my favorite collaborators and who co-leads the CARA Health Equity Research Work Group. And essentially our initial question was whether or not the missing data on critical variables in the CARA registry was not randomly distributed across groups, but socially patterned. And how was that potentially influencing the results that people were deriving while using the registry to answer important research questions about lupus outcomes? So with that, I'm going to pass the mic to Jen.
Thanks so much. Yeah, as Tamar mentioned, these are really important questions, especially when you're trying to use a health equity framework and lens, since we don't want to perpetuate or exacerbate existing health disparities when we're doing this type of research. Next slide. So in order to answer these questions, we use baseline data from the CARA registry for participants enrolled between 2015 and February 2022. And so eligible participants were those youth diagnosed with CSLE, which were classified as either 4 American College of Rheumatology criteria or 2 ACR criteria in addition to renal involvement, and all before age 18. So ultimately, our analytic sample consisted of 766 participants. And since this was a proof of concept study, instead of looking at all the variables in the database, we looked specifically at 12 variables in our analysis, including 3 demographics, 4 socioeconomic characteristics, and then 5 clinical variables. And for our statistical models, we applied 3 different methods used to address data missingness and used regression models to estimate both the odds of missing clinical data, as well as the risk of greater SLEDAI or SLE disease activity index score as a measure of disease activity. Next slide. So the 3 missing data methods that we used were complete case analysis, multiple imputation, and then non-probabilistic bias analysis. And we picked these because they represent a range of commonly used methods, as well as varying based on ease of implementation. And so you're probably most familiar with complete case analysis, in which all records with any missing data are removed. And the main benefit from this method is that it represents real data. However, the downside is that there's a high potential for loss of data depending on the levels of missingness across your different variables. The second method that we used was multiple imputation, where we use known data in order to predict missing values. We run the analyses in these different data sets, and then we pull the estimates across the multiple data sets in order to get a final estimate. And then the largest benefit of this method is that all the available data are used. However, imputed values are based on existing values, so they're really only as good as sort of the existing or underlying data. And then finally, we used a method called non-probabilistic bias analysis, which may be the least familiar method, but in this method, missing values are imputed to the hypothesized extreme values. So in our case, we imputed to values representing sort of the least and the greatest disadvantage. And so the main benefits of this method is that you can retain more observations in your analyses, and that the extreme estimates can be compared in order to assess sort of this potential range of outcomes. However, this method is sensitive to hypothesized values, so they should really be grounded in theory or plausible biologic or psychosocial mechanisms. Next slide. So when we're looking at our sample, 50% were missing at least one variable of the 12, and about 10% were missing greater than 10% of variables. So on this slide, we present the demographics of our sample and then highlight the percentage of missing data for each variable in red. So overall, our sample is predominantly assigned female at birth and racial and ethnically diverse, with about 30 to 40% reporting either low household income, low parental educational attainment, as well as government assisted or no health insurance. And you'll note that household income had the highest level of missing data, where 20% preferred not to answer the question, and an additional 15% had missing data. And then furthermore, the mean SLE or SLEDI score was 7.1 out of 105. And while this might seem low on the full scale, this actually represents moderate to high disease activity. And of note, about 12% of participants were missing this data field. And so while our sample appears fairly diverse, we were really interested to see how the patterns of missing data impacted our estimates. So this heat map represents the tetraporic correlations between missing and non-missing data. So whether or not the value is missing, not necessarily the variable categories themselves. So blue represents inverse correlations and red represents positive correlations, with darker colors representing stronger correlations. So we can see in this figure that outside of correlations within the same class of variables, we see the strongest correlations between demographics and clinical factors, which is in sort of the bottom left corner, as well as moderate correlations between clinical factors and insurance status. Next slide. So next we looked at the odds of missing clinical data associated with different demographics and socioeconomic factors. And the statistically significant findings are highlighted in red. However, the most notable finding was that reporting either government-assisted insurance or no insurance was associated with over 2 times greater odds of missing clinical data in our cohort. Next slide. So in our main analysis, we looked at the association between social determinants of health and SLEDI scores using our 3 methods to address missing data. And we show 2 examples here using household income and insurance status based on the level of missing data, and then as well as the association with missing clinical data. And I want to highlight how the sample sizes in blue vary between each method, with complete case analysis losing about half of the sample in the analyses. For the non-probabilistic bias analysis, we imputed most disadvantaged as either household income less than $25,000 and having no health insurance, shown in red. And then the least disadvantaged groups were represented by household income greater than $100,000 or having private insurance, which is noted in green. So the estimates, So the estimates presented represent predicted changes in SLEDI scores compared to the reference group. And for the purpose of this study, we're interested in sort of the changes in magnitude and direction that occurred when different missing data methods were used. So for example, the estimates for household income less than $25,000 seen in that first line range in both direction and magnitude compared to the highest income category. Whereas the estimates for reporting no insurance compared to private insurance, which is on the bottom row, demonstrate greater SLEDI scores despite the missing data method use. So the patterns of these findings are indicated with the pluses and minuses in the column on the right. And as you can imagine, if we relied solely on complete case analysis, then the interpretation of these findings could be very different than if we implemented more intentional methods to address missing data. Okay, next slide. So the main takeaway question that we're asking is, like, do we really know what we think we know when we're running analytic models? And so as we've demonstrated in this proof of concept study, missing data can influence estimates based on the strategies that are implemented or not implemented in order to address them. So therefore, it's really important to consider trends observed using different methods and then their implications on subsequent interpretations.
So in the last couple minutes, I just wanted to share how these findings influence the design of a study we're calling ECHOES, Engagement in Childhood Onset Systemic Lupus. Because we wanted to investigate engagement in a high-risk population, we decided to focus on our own institution's population in the Bronx, New York. The star here reflects where our hospital sits in the North Central Bronx, and we serve a population that is majority Black and Hispanic and low income. 85% of our clinic population is Medicaid. So I already gave you a little bit of the background behind the rationale in choosing engagement as a target, and I hinted as well to why we wanted to look at depression as a specific predictor, but this message probably more succinctly and elegantly expresses the relationship between depression and engagement that we think exists than anything I can say. Sorry. Before launching the study, we did a preliminary look at our clinical lupus cohort of adolescents and young adults, and this is what we found. First, there's a remarkably high rate of disengagement in our population. So 45% of youth between 15 to 25 had a gap of 6 months or more without a lupus visit in a 1-year observation period. And this is clinically significant because our standard of care is that even when lupus is well controlled or relatively inactive in this age group, we still think it's important to monitor patients every 3 months. Unsurprisingly, we also found that youth with reported unmet social needs on a clinical social needs screener that we use in clinic and administer in clinic were more likely to have a history of gap in care. So this supported the need to investigate disengagement in our population, and our primary study has 2 major aims that actually describe 2 sub-studies. The first sub-study is an observational study with the aim of investigating the longitudinal relationship between depression symptoms and engagement in care in adolescents and young adults with lupus, with our primary hypothesis being that anhedonia as a construct of depression may predict disengagement. But we also want to look at other addressable factors, specifically looking at specific social needs that may impact engagement in care and in the future be a target for intervention. The second sub-study is an interventional study where we're using patient-engaged methods to adapt an existing mobile health app called Bolera Health. And we want to assess the feasibility and acceptability of this app. So we learned several lessons from the paper we previously described that have influenced our study design, and I'll go through this real quickly. But first and foremost, the importance of recruiting high-risk patients and being sensitive to bias that might exist in our study cohort, because people at high risk for disengagement in care are by definition likely harder to engage in research. To ensure this, we'll be targeting patients with a known history of disengagement, and we'll be doing bias analyses to assess for major differences between our study cohort and our clinical cohort. And finally, we'll have to carefully investigate patterns of missing data with sensitivity analyses to attempt to address these. But we haven't given up on the power of the CARA registry. We still think it's important to investigate the extent of disparities in youth with lupus in a large, diverse cohort and risk factors for disengagement to better define who we should target in future intervention, development, and testing. And despite its limitations, the CARA registry is really unique in its ability to provide in-depth data on a diverse and large group of youth with lupus. However, we've demonstrated that we need to use an analytic design to address socially patterned missing data. So we just want to thank you for your attention today. Again, I'm sorry about not sharing the first 2 slides. We want to thank our amazing teams. We have an amazing ECHOS team in the Bronx that's helped me develop this project and will help launch this project in the coming weeks. And we have an amazing CARA Health Equity team that worked on this paper and were co-authors for this paper that we presented. And we'd like to acknowledge our funders, NIAMS, which is funding a K23 award, as well as grants from CARA and the Arthritis Foundation. And then finally, we have to acknowledge all the participants and the hospital sites involved with the CARA registry, along with the site principal investigators. Thank you so much.
Wonderful, ladies. Thank you very much. Due to time, I'm trying to see. Please put your questions in the Q&A. I don't see any at this time. But to make sure we stay on time, I'll just thank you. And we really appreciate all the work that you're doing in this space. Next, we will hear from Dr. Margaret Kuklinski, who is an endowed associate professor of prevention at the University of Washington School of Social Work. Please join me in welcoming Dr. Kuklinski.
Thank you, Dr. Parker. Let me just share my slides. Here. Okay, I hope that you can all see that. Thank you very much for inviting me to present Sometimes More is Better, Cost Effectiveness of Single and Multi-Component Interventions for Students with Disruptive Behavior Problems. So we're going to go in a very different direction now from the first presentation that you just heard. I want to begin by acknowledging my co-authors, funding support from the Institute for Education Sciences, and the school districts in Kentucky and Indiana, including the schools, principals, teachers, students, and their families who participated in this study. And I have no conflicts of interest to disclose. All right, this talk today has 3 parts. First, I want to say a bit about why health economics matters to investments made in a nurturing society. And by that, I'm referring to significant levels of public and private funding that are aimed at supporting healthy outcomes in young people. I'll then turn to 2 interventions, First Step Next and Home Base, that are aimed at preventing or reducing disruptive behavior problems, which are a common concern among young people. And then I'll turn to assessing their cost effectiveness. So over the last 40 years, preventive interventions have been developed and shown to be effective in reducing a wide range of behavioral health problems in young people. So primary question for us now is, how can we motivate investments in these programs, policies, and practices and raise their profile so that we can better support young people through investments at federal, state, and local levels? Well, Dr. Nora Volkow points us to one way. She says that when we can translate the human benefits of interventions into some quantifiable return on investment, that can be a lever to shift public health policies. Economic evaluation is that lever. Broadly speaking, it provides a systematic approach to estimating and comparing the investments in and outcomes from intervention programs, policies, and practices. And because a metric for economic evaluation often is dollars, the results tend to have practical and policymaking utility. So economic evaluation can be that lever, that translational lever to increasing impact. A major method in the economic health evaluation toolkit is cost analysis, which answers a very straightforward question of how much does a preventive intervention cost? That information is useful to decision makers, but on its own, it doesn't tell us if investments are worthwhile. That is, whether they're a good use of limited resources. To make that calculus, we have to turn to methods that compare costs to outcomes, that look at what you put in as well as what you get in return from an investment. Cost effectiveness analysis is a major method for achieving this goal of understanding which preventive interventions are good investments. It tells us the cost per unit gain of an outcome. So imagine for a second we have an intervention that aims to improve high school graduation. Cost effectiveness analysis could help us understand what the cost of achieving one more high school graduate using that particular intervention approach is. So that cost per unit gain is important, but it doesn't by itself tell us whether an intervention approach is cost effective. To do that, we need to compare the cost per unit gain to what decision makers are willing to pay to achieve those improved outcomes. And that's the focus of the presentation today in terms of disruptive behavior problems. So disruptive behavior problems, and by that, I'm referring to things like ADHD or conduct disorder or oppositional defiant disorder, are among the most common behavioral health concerns in children and adolescents. They cause significant pain to children and their families, and they can be difficult to manage in the school environment. They also place children experiencing these concerns at increased risk for a number of other behavioral health problems. They're also costly, both on an annual basis and also across the multiple years over which young people tend to experience these issues. So from both a well-being and an economic standpoint, it makes sense to think about, to put effort into preventing or reducing disruptive behavior problems. Fortunately, some effective intervention approaches have been developed. One of them is called First Step Next. It was developed by Hill Walker and his colleagues at the Oregon Research Institute, and is a classroom-based intervention that takes about 3 months to complete. It involves a partnership between teachers, behavioral coaches, students, and their parents or caregivers. And the 3 major tasks involved in the intervention are aimed at improving social skills in children, helping them be more on task in the classroom, and both of those things provide an underpinning for better school performance and achievement. So that's one approach, a classroom-based approach. It's also possible to work in the home environment because disruptive behavior problems can be challenging for parents at home too. So home base is a home-based intervention involving 3 to 6 60-minute one-on-one sessions between behavioral coaches and parents or caregivers of children who have disruptive behavior problems. Coaches assess parenting skills and then across those sessions provide tools, skills, and strategies to strengthen them consistent with positive behavior support principles. Importantly, the efficacy of home base as a standalone intervention had never been evaluated, although First Step Next as an intervention has been shown in several trials to be effective. Excuse me for a minute, my computer was slow to respond. So Andy Fry and his colleagues about 8 years ago received funding to start a 4-arm comparative efficacy trial that allowed them to assess whether First Step Next and home base as standalone interventions were effective in reducing a number of primary outcomes, primary disruptive behavior outcomes, ADHD, oppositional defiant disorder, conduct disorder, and comorbid ADHD and conduct disorder. They often co-occur. But they also wanted to see if a combined, a multi-mode intervention consisting of both FSN and home base would also be more effective than a control arm in which children received business as usual services. So with funding support, they implemented this 4-arm trial with 379 students in grades kindergarten, first, second, and third, 1 child per classroom, in 100 schools across 5 districts in Kentucky and Indiana. Children were eligible for the trial if they scored in the borderline or clinical range on the CBCL externalizing scale after completing some screening assessments. After randomization, those 4 trial arms were demographically the same. I'm going to say just a little bit about the demographic characteristics of the sample so you can get a feel for it. Most of the participants were male. They identified generally as Caucasian or Black. They were evenly split across grades K through 3. Many children were eligible for their school's lunch program. Many did not have an IEP. And about 2/3 were rated by their teacher as the most challenging in the classroom in terms of disruptive behavior problems. Importantly, at the end of the trial, Dr. Fry and his colleagues found that First Step Next as a standalone intervention, or the multi-component First Step Next and home base, consistently improved several clinical outcomes: ADHD, conduct disorder, and comorbid ADHD and conduct disorder, although not oppositional defiant disorder. They also found that home base was not effective as a standalone intervention. These results led Dr. Fry and his colleagues to want to understand whether First Step Next and the combined intervention not only were effective, but also were cost effective. Cost effectiveness analysis provided us with a way to answer their questions. It involved 2 steps. For each of the 2 interventions, we needed to estimate the intervention cost and the improvement in the outcome. We needed to then compare them to the control arm cost and improvement using the incremental cost effectiveness ratio, or ICER. The ICER is the difference in costs divided by the difference in effects, also shown here. And in general, lower ICERs are desirable because they indicate that the alternative doesn't cost much more than the control condition, or it's much more effective than the control condition, or some combination of the two. In order to determine if the interventions were actually cost effective, we needed to compare those ICERs to what decision makers were willing to pay to achieve improvements in disruptive behavior disorder. Let me share with you first what we found in terms of costs and effects of these two interventions. So it cost about $2,500 per student to implement First Step Next in this bar on the left. Most of that cost was for personnel. 54 hours, in fact, were spent per student, largely on the part of coaches, next on the part of teachers, with a small amount of management time. Costs for supplies and overhead were relatively small. The combined intervention cost about $200 more per student, primarily because it took more time, 6 more coaching hours, and also some time on the part of parents. This chart on the right shows what these interventions yielded in terms of the percentage of children displaying clinical improvement in 3 different clinical outcomes at the 6-month follow-up point. Results for the control arm are in the pale blue bar, for First Step Next in the medium blue bar, and for the combined intervention in the dark blue bar. And at the bottom of the chart, you can see the numbers of children who improved and the odds ratios comparing the intervention to the control arms. There are 3 things that I hope you see in these results. The first is that both intervention arms outperformed the control arm for all 3 clinical outcome measures. And by clinical improvement, it's a child moving from a clinical level of concern to a non-clinical level of concern, for example. The second thing that I hope you can see in this chart is that the combined intervention also outperformed the single component FSN intervention, and that was true across all outcomes. And then in general, results were strongest for ADHD, followed by conduct disorder, and then the comorbid outcomes, which are generally more intractable. So we have the costs and effects, and on the next slide, I want to show you the cost effectiveness. So remember that cost effectiveness refers to the cost of achieving a unit gain in an outcome. And by unit gain, I'm referring here to one case of clinical improvement. So a child improving clinically at the 6-month follow-up mark. What you can see is that for First Step Next, that improvement cost $12,000 per child improved, a little bit more for conduct disorder, and more still for ADHD and conduct disorder in a comorbid situation. The combined intervention showed that same pattern of the lowest ICER for ADHD, increasing to the comorbid outcome. But what you can also see is that the ICERs for the combined intervention are lower. It cost less using the combined intervention to achieve improvement in each of the 3 clinical outcomes. So although the combined intervention costs more, the extra impact was such that overall it was more cost effective. Can we say that it's cost effective in absolute terms? Well, that depends again on how these ICERs, these incremental costs to achieve a unit gain, relate to decision maker willingness to pay. And that's what you see on this screen. On the x-axis, we have decision maker willingness to pay values that range from 0 to I'm not willing to pay to improve disruptive behavior disorder at all, to as high as being willing to pay $100,000 to improve disruptive behavior problems. The curves on this chart are called cost effectiveness acceptability curves. and they show the likelihood that an intervention is cost-effective at any value of willingness to pay. They're generated by simulations. The methods are detailed in the paper. I don't have the time to share those methods here, but the important thing to know is that the probability increases as the willingness to pay increases. And I want to bring home the message here with some real-world willingness to pay values. So let's say I was a decision maker whose willingness to pay was about $6,000, which is the annual cost of ADHD to schools. If that were my willingness to pay threshold, those interventions wouldn't be very likely to be cost effective. But if my willingness to pay is just a little bit higher, the total cost of ADHD all up, not just to schools, the likelihood that this intervention is cost effective increases a lot. If my willingness to pay is the annual public cost of conduct disorder, it's even more likely to be cost effective. And if it's instead the public cost of conduct disorder in middle and high school, it's nearly certain that the intervention would be cost effective. So to me, these results suggest that the combined intervention is highly likely to be cost effective at what seem like reasonable thresholds for decision maker willingness to pay. So to conclude, both of these two interventions significantly outperform the control arm with respect to improving a range of disruptive behavior problems. In the comparative efficacy trial, though, more was better. The multi-component intervention involving home and school components cost just a little bit more per child, but yielded much better clinical improvement such that it was more cost effective than the single component school-based intervention. And finally, these are problems that are painful to children and families and cost society a lot. And I do believe that the willingness to pay analyses shown on the previous slide indicate that they're highly likely to be cost effective at reasonable willingness to pay values. And so with that, I thank you for your interest, and there may be time for questions.
Thank you, Dr. Kopensky. This was very nice. I'm not seeing any questions in the chat, but I have a question as people may be thinking about ones to enter. I think what hit home for me is hearing about this willingness to pay.
Mm-hmm.
And when school districts are put in situations to think about paying, let's say, for better infrastructure or resources versus investing in child behavior, how do you make that case that this is the better investment?
That's a really, really great question. And to that, I would really say that your question highlights the fact that economic evaluation methods are decision-making tools. They provide information about the costs, the benefits, the return on investment of different interventions and other choices that we have about how to spend our money. I think that what you're getting at, making the choice of investing in infrastructure or in interventions to prevent disruptive behavior problems, that really begins at a level of values and priorities. And I think that once you decide what is most important to you as a school partner, decision maker, somebody who is invested in that space, once you make that values-based decision about which sphere feels most important to you now for a number of complex reasons at a values level, then you can use your health economics information to understand what it costs or to understand what alternative approaches in that space are. But I think that the economic information alone, it can't tell you exactly what you do, because I think it's values and priorities that come first. I hope that makes sense. I'm not trying to.
No, it totally does. I just,
Yeah.
you know, wanted to hear more thought around it because it is a challenge.
Yeah.
There are a couple questions. I will ask this one because this one probably has a short answer. Dr. Wade would like to know, has the study compared the cost-effective connection to youth prison increases?
They have not, in this particular study, they haven't done that. I will say benefit cost analysis is another tool in which we can look at return on investment and effective preventive interventions. And if we can reduce incarceration, that tends to be a very cost beneficial intervention. When we show those better outcomes in the juvenile justice or criminal legal sphere, they do tend to be cost effective and cost beneficial because those outcomes are so costly in so many ways. So I hope that is helpful there.
Well, excellent. Thank you again for this great presentation.
You're very welcome. And thank you very much for having me.
You're welcome. Awesome. So to wrap up our day, I'm very happy to introduce Dr. Perry Sheffield to you. Dr. Sheffield is an associate professor from the Icahn School of Medicine at Mount Sinai. So welcome, Dr. Sheffield.
Hi, thank you very much. I'm Perry Sheffield, as you just heard. I'm based at Mount Sinai in New York City, and my co-principal investigator on the parent study, about which I'll talk today, is Jane Clougherty, who's based at Drexel University in Philadelphia. And the work that I'm presenting today was led by Dr. Lee New. She was a former postdoc with our team, a valuable contributor, and she is now on psychology faculty at Beijing Normal University in China. So she's not able to present today. So the paper that we published in Epidemiology and Psychiatric Sciences last March focused on temperature and mental health impacts among young people. But first, a little bit of background. High temperatures are associated with considerable morbidity. And given the warming climate, this is a growing risk and warrants better understanding of both the burden and disparities in impacts to inform prevention efforts and motivate them as well. So growing research has shown increased pediatric hospitalizations and emergency visits associated with high temperatures, and subpopulations of children and adolescents are that are most susceptible to these elevated outdoor temperatures really remains understudied. We know that children in general are a more vulnerable group at risk to the adverse effects of heat because of a number of features of children. Their greater body surface to volume ratio, which means they can sweat or lose fluids more quickly and become dehydrated and have health consequences that way. They're less able to regulate their core body temperature. They're more prone to behaviors that increase exposures, like outdoor play, and they're less able to self-care compared to adults. Less agency in that regard, particularly the young ones. The very young ones. So some subgroups of children that have been found to have higher risks of morbidity associated with heat that compared to the general population are the very young children. Our group had previously found higher risk of healthcare utilization for children under 5 was associated with these high outdoor temperatures. And we had seen an uptick in heat stroke, heat illness, specifically, but then also some ones that were a little bit more surprising, respiratory illness, gastro and intestinal infections, and viral infections. So in other prior work that we had done using data from New York City, we saw other subgroups among those children with different risks of going to the emergency room or the hospital or getting hospitalized when there were hot days. Particularly during the warmer months, May through September. And specifically, but some of these findings were actually not necessarily in the direction that we originally thought. So children with asthma children with obesity or children with mental health disorders actually had a decreased risk of emergency department visits, but in some cases had an increased risk of hospitalization. Children with sickle cell trait had an increased risk of emergency department visits. So we had observed this complex pattern of risk between temperature and admissions. The direction and the strength of the association, you see some very variable effect estimates there. Depended on the chronic conditions that we were considering, the time frame that we looked at, and some other sub-analyses, and which type of healthcare utilization. So we thought maybe this was related to, in some cases, the heat might make things more severe. Sometimes the heat might shift behaviors that actually then subsequently protected children more. And so we were intrigued by these findings. We wanted to further understand, unpack some of them, and we decided to look more closely at mental health. So just a little bit of background on that before I dive into our specific project. Mental health disorders affect between 13 and 20% of children and adolescents in the US. And we know that mental health hospitalizations increase with age, spiking around 12 or 13. There's sort of an uptick, but then a steady increase all the way through into young adulthood as well. Furthermore, mental health disorders are costly. So we just heard a little bit of some of them in the last presentation. It's one of the most costly conditions. The diagnoses that are most common among pediatric admissions include depression, bipolar disorders, and psychosis. And you can see that those are some of the most costly listed here in the graphic. So then, in terms of what we knew before going into the study about heat and mental health disorders, we knew that from past studies, we had seen not us, our team, but other literature suggested an increase in mental health admissions among during hot weather among adults. So we knew older groups were affected. Heat triggered irritability and acute psychologic distress, and reduced cognitive function. To be able to avoid outdoor heat exposures were hypothesized to be sort of maybe the underlying mechanisms of why they were seeing that. Very few studies had examined heat susceptibility across childhood and adolescence, which is where we decided to focus, and into young adulthood. So we unpacked this further and looked specifically at characterizing specific subgroups and mental health categories that may be exacerbated by high temperatures. So this study, as I said, looked at children, adolescents, and young adults. So 0 to 25 initially, and then we ended up parsing that to be 6 to 25 because of the prevalence of mental health diagnoses, as you can imagine. And while we started with a large data set of emergency department and hospitalizations, we then pared that down to focus on warm season months, which I'll show you in a minute. And this used data from a New York State database called SPARCS, or the Statewide Planning and Research Cooperative System. And we were using data that is a bit dated now, 2005 to 2011. And we identified the mental health disorders primarily by their diagnostic codes, their ICD-9 codes, as well as suicide, which then ended up getting pulled out for some sub-analyses. In the climate exposure data, we used daily minimum temperature in the New York City area that was recorded from national weather data. And we chose that because there's some growing evidence about how the nighttime temperatures are actually increasing more quickly than daytime temperatures because of some urban built environment factors. And there's also a link between those increased nighttime temperatures and sleep disturbance, which we think might be one of the main mechanisms. So ultimately, we had a total of about 82,000 visits that we were looking at. And here is some pie chart showing you the distribution of those. So we saw that about 3/4 of those were ED visits, or the other quarter being hospitalizations. About 40% of those were young adults, which was consistent with what I showed you earlier, the increasing rates of mental health disorders as children age, as humans age. And then looking at it by diagnosis, you see there were many groups, but the two largest had to do with substance use and externalizing disorders. So that would be conduct and oppositional defiant disorders, making up the largest percentiles, but heavy representation in depression, bipolar, anxiety as well. In terms of sex, it was slight predominance of male. Sex was 56%. And then across race and ethnicity groups, about 35% were non-Hispanic Black. That was the largest proportion, and about a quarter being Hispanic. So here I'm showing you some of the results of the study. Once we looked at this minimum temperature and how the minimum temperature on the day and the preceding 5 days, this in the months of June through August, how that was associated with the odds of either coming to the emergency room or being admitted to the hospital for a mental health condition. And you can see that there's variety by the different age groups. We put them in 3 bins, 6 to 11, 12 to 17, and then 18 to 25. And we see that younger children showed more sharply increasing odds with the higher temperatures. But we saw an effect in the middle adolescent group as well. And then a blunted effect, but still significant, in a fairly modest temperature, but warmer temperatures, and not necessarily the extreme temperatures for the young adults. So before I go to the results of the subgroups, I also just wanted to share that a little bit more about the common mechanisms that could underlie this vulnerability to high temperature in terms of mental health risk. So some of these include sleep disturbance, as I just mentioned, heat stress or dehydration, and we think specifically that contributes to altered neuroendocrine chemistry. And there's also some suggestions of social aggression mechanisms in the setting of hot weather, irritability, if you could think about that, and that potentially leads to conflict or violence that maybe is sort of an exacerbation of an underlying mental health condition. We also think that potentially people who are struggling with mental health conditions might have impaired cognitive awareness that in the absence of, they might have other coping mechanisms to help deal with the heat, maybe just the frequency in which they're staying hydrated, for example. So now by subgroups, we saw elevated odds among subgroups within different ages. So here are children at the top, adolescents, and then young adults. These are the same age categories I just showed you, but now broken down, and I'm showing you where there were significant odds among different subcategories. So for race and ethnic groups, the odds ratios were higher among some groups where we already know that there's widespread health disparities, such as the non-Hispanic Black children and youth. But these results were not statistically significantly different by race based on some of our other sort of quantitative analyses to look at it, but we did see these elevated relative to the other groups. In terms of insurance, which is sometimes used as a proxy for economic resources, younger children and the young adults that were on Medicaid had elevated odds of mental health visits during hot weather. But the adolescents were those that were on commercial insurance and the elevated odds. In terms of types of mental health diagnoses that are most strongly associated with these temperature differences by age group, we saw reaction disorder for children, anxiety and bipolar disorders among adolescents, and psychosis and reaction disorders for young adults. So, in summary, our study provided additional evidence that heat is associated with morbidity, specifically acute mental health encounters. And the strongest associations were observed among children and adolescents, though they were still elevated in young adults as well. And in terms of differences in types of mental health diagnoses that were associated with temperatures, that differed by age group. Our findings were consistent with the recent national study of adults that also found associations between heat and schizotypal and anxiety disorders that had overlapping diagnostic codes with our psychosis and reaction disorder categories, where we saw that was consistent for the young adults. So some interesting findings. In some ways, it supported the literature that already existed, broadened our understanding of the age groups and how and variety of through which some heterogeneity through which they're affected. But as research also does, raised additional questions about why we're seeing this variety, and also leads us to inquire more and potentially be able to tailor our questions in order to lead to more specific prevention strategies. So an acknowledgement, and I acknowledge my co-authors, particularly Lee New, who led this effort, our funding from NIEHS, and other team members who have contributed longitudinally to this work prior to this specific publication and in an ongoing way. So thank you very much.
Excellent. Thank you, Dr. Sheffield. We do have some time for some questions. So again, please put them in the Q&A box. In the meantime, I think I can get this started perhaps. Can you speak to, I mean, maybe it's the next study, but how do we now take this data that you've shared and extrapolate information about some of the social determinants that may be feeding into what you're seeing, you know, housing stability, education opportunities, things like how do we now extrapolate again some of the intersectionalities there?
Yeah, I agree. Super interesting question. And yes, probably the work of future studies to be able to unpack that. But in some of the directions that I would go, thinking about it from an environmental epidemiology, and thinking about the exposure to heat and some of the social or structural determinants that contribute to those. We know, for example, that air conditioning prevalence is not equitably distributed, not only in houses, the presence of air conditioning, but also the ability to pay the energy bills. So the willingness to run it, or the ability to run it, but also in educational settings, that air conditioning is not evenly distributed across all schools in a single climate area. And furthermore, in cities, we know that there's certain microclimates of heat. And so certain areas that are less likely to have air conditioning in cities, in New York City, for example, certain schools that are less likely are in neighborhoods that are hotter because of some of the social determinants of health in terms of the built environment. So green space, paved surface, things like that have now made those areas hotter. One other area that I would think about that's interesting is sort of the prevalence of people taking public transportation. And while big fan of public transportation for a lot of reasons, we know that it does mean that you're outside more, waiting for buses or subways, and so that can increase your exposure to heat. So I think we have to think about it through all those different potential mechanisms and think about some of the choices that people do or don't have in terms of their exposures. It's not nearly as simple as saying it's hot, don't go outside, right? We know it's a lot more complex than that.
All right, thank you for answering that. I am looking in the Q&A, not seeing anything, but we're almost right at time. So I will just wrap this up and say, you know, on behalf of everyone, I want to thank you, Dr. Sheffield, as well as all the speakers from this session for very informative presentations. As you can see, we all have a role to play in encouraging kind of optimal health for our youth and creating a world where young people can thrive. So the next voice you will hear will be from Dr. Simone, who will provide closing remarks. So thank you all for an excellent day.
All right, well, thank you very much. It's been my privilege to open this research festival, and it's my pleasure now as we close it and end the day. I want to say I was truly impressed with a lot of things about the presentation. I'll be brief too, because I know it's been a long day as well. But just the multi-level nature of them, something that we had talked about, how diverse they were in terms of interdisciplinary science. And in the population studied, I saw different geographies, ages studied, socioeconomic status, race, ethnicity, sexual and gender minorities. And I think this is great population to study. And I would like to see us continue to diversify the scientists doing this work. That's something that's definitely a priority for our office. But it was wonderful to see the assistant professors as well, already making a mark in their field. So very happy and thankful for all the speakers really in their presentations. The moderators as well did a great job. It's not easy to do that, to kind of scan the question and answer as you're listening to the talks, but you did a great job. And finally, to the participants as well, also not so easy to do, to be on the call for that long, but we appreciate the questions you have. And think that really helps with a more engaging presentation. Before I forget, also the conference team did a great job. I want to point them out again. Those I recognized in the beginning, both for running the conference and all the preparation that goes into it. Next week, we'll start planning next year's. I'd like to let you know that a full recording of the entire festival will be available on our website in about a month or so. And if you visit our OBSSR website, you can also see about the work we're doing, learn about future events, and some of the funding opportunities that I mentioned early in the talk. You can take a look at those, and please feel free to ask us more about them, talk to the project officers at the different institutes that are co-sponsoring them, and let us know if we can be helpful in circulating that to others who you know will apply. And there in the chat is the website that you can click on and go right to. Unless there's anything else the organizers want to add to that, I think we're about ready to wrap you up and give you actually a couple minutes back at the end of your day. Thank you very much for joining, and I hope to see you all again next year.